Starting it. Sure.
You are live.
Check with audio. You speak near the camera.
Hello, hello, hello,
Full sound on, please.
hello, 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 hello.
It's getting late. Delayed, right?
Yeah. It's usually
yet slowly slipping away. Dementia is not just a loss of memory, it is a loss of connection, of self. It touches lives, not just of those who have it, but of those who care for them. Caregiving is a journey, often traveled in silence, often unrecognized. For every person with dementia, there is a caregiver, a loved one, a spouse, a friend, a child, who faces this journey with courage even as their own lives are reshaped by it. This is where Dementia India Alliance, DIA, steps in.
We've been in dementia space for nearly 18 years, and we have noticed families who look after people with dementia are running from pillar to post to even get a simple diagnosis, looking for good services, advice. So that's why we started with Dementia India Alliance. Here we are trying to give them help and hope.
The IA is founded by people who are greatly involved in the patients who are suffering from dementia and the equally important aspects of caregiving. Some of us have managed care institutions, others have been family caregivers. We know the challenges, the heartbreaks, the small triumphs, and the difficult journey.
Dementia India Alliance, it's just not a name, it's a movement of change. It's a beacon of hope for persons with dementia as well as their families. The National Dementia Support Line and DEM Clinic has been giving families across the country vital access to help and guidance since 2023. Our Blue Button movement has reached 6 cities, benefiting over 1,500 people as we raised awareness and connected communities in a powerful way. Our support group meeting with NIMHANS have helped over 800 family carers find strength, understanding and companionship. And our educational workshops in 6 cities have reached 1,200 people, spreading knowledge, reducing stigma and empowering families.
There are a lot of NGOs working in our country for the cause of elders and dementia, but most of them are working in silos. We feel unless we have right policies at government level, we cannot make a larger societal impact and serve all segments of the society.
At DIA, we are building a world where dementia doesn't isolate but brings people together, where caregivers find hope, where each person touched by dementia feels seen, valued and cared for. So stand with us, join hands to bring dignity and compassion to every life touched by dementia. Together we are stronger, together we can find moments of joy and peace amidst the challenges. Together we can bring help and come be a part of dementia.
Turn that on. Turn the audio.
traffic, so we got a little delay. We are ready to start though, so please take your seats. To share practical strategies and empower all of us to become better allies in improving the quality of life for those living with dementia. Once again, thank you for being here. I will now welcome the Executive Director of Dementia India Alliance, Ms. Ramani Sundaram, to set the context for today's program.
Thank you, Roger. A very good morning to one and all present here. First of all, apologies for those who are not able to find a seat. We are trying to arrange. Please do bear with us for that. Just to set the context, first of all, I think we all can share a little bit of success on getting that awareness together in the society. Today's program, we are trying to concentrate on the risk factors for dementia, why we need to know about them and how important it is to work on risk reduction. As we all know, dementia is emerging as an epidemic. Once a person gets dementia, of course there are management techniques that we do use, but then prevention is always better than cure, and currently we want more dialogues around prevention. And when we want more dialogues around prevention, it is also important that we are able to identify those risk factors. That's why risk screening, cognitive screening is also very important. That's why these two topics have been now put together for a panel discussion. We've got eminent speakers from different organizations who have years of experience, decades of experience in this field, and they'll be engaging in some very thoughtful conversation. And we hope that you all can ask good questions. You have many queries that we saw in the registration forms. You're open to engage in those discussions as well. As Dementia India Alliance, that's what we want to do. We want to see a aware society where people are open to talking about brain health, people are open to talking about dementia. We are able to mitigate the stigma and spread more awareness. Without any further ado, I request Roger to get us through the program of today. Thank you very much.
Students, if you can please help the seniors sit down. and then we'll arrange chairs for you guys. So for the first panel for the day, it's my pleasure to welcome Dr. Dominic Benjamin. Dr. Dominic began his medical journey at St. John's Medical College. He then went on to become a postgraduate in internal medicine at St. John's. He then had a deep desire to serve older adults. So he moved to the UK, where he specialized in geriatrics and gerontology. After his training, he worked as a consultant geriatrician there. He then made the decision to come back to India with a mission to raise awareness and enhance the care of older adults in India. He set up the Department of Geriatrics in Bangalore Baptist Hospital, where he continues to serve with dedication and vision. He's not only a clinician, but a passionate teacher. He's an international MRCP examiner and actively involved in the training of PG students. He's part of the DEM clinic panel that Dementia India Alliance runs. And I had the pleasure of joining Baptist Hospital with Sir. I was there for a brief moment, but Sir continued on there. So it's my pleasure to welcome Sir. He will introduce the first panel of speakers. Please put your hands together to welcome him.
Roger, thank you, and Ravi, thank you, and DIA, thank you for the opportunity. I just want to salute each one of you for the life that you lived, for the blessing that you're being to each one of them in your life, and the life that you touched. And it's so wonderful to see so many people sort of come in to learn and to deliberate and to know more about it. Aging is intricately connected with cognitive decline, and that's the way it is. We accrue both physical and cognitive reserve over the life course. What we're going to do in this panel discussion is to talk about how to mitigate or assuage the risk factors. So I have a wonderful panel with me. So I want to invite Dr. Thomas Isaac, who is a associate professor of Center for Brain Research. Please come. Dr. Jonas is assistant professor, Center for Brain Research. Gentlemen, please come. Dr. Steve is a consultant geriatrician at Apollo Hospital. Please join us. And Dr. Girish, who is a professor in ophthalmology at NIMANS. Please join us, please. Gentlemen, please join. Okay, what we're going to do is that I'm going to set some narratives. Okay, so what we're going to do is that I'll give some narratives to them so that it will change our perspective. It's much easier for you to hold on to a story than be talking in abstraction. Okay, so the first question is for Dr. Thomas. So this 71-year-old gentleman who's had diabetes, hypertension, his memory is fading. He comes to the clinic and they use a fancy word called MCI. And his wife is very concerned that his husband may develop dementia. One of his uncles had dementia. It is quite brutal. So, Dr. Thomas, tell us and help us to understand how can a husband increase the cognitive reserve or delay the development of dementia? And also, she wants to know how can she get better not to be in that state?
Yeah, thanks Dr. Dominic, and thank you all for coming here. We are happy to host. I am from CBR. So just jumping right into the question. So you have a 71-year-old person and the wife and both of them come with mild cognitive impairment. So mild cognitive impairment is actually a pre-dementia condition. It's something which happens before dementia and can actually precede dementia by a decade or two also. So it's a situation when there's an objective as well as a subjective identification that you are not as efficient like before. So there will be issues with your memory, issues with other domains of cognition like complex attention, executive functioning, social cognition, and even perceptual motor abnormalities, all that. So what will happen is when they actually come, MCI is a condition when there's both a subjective as well as an objective realization that the particular person is having a cognitive decline. But the functioning is essentially normal. For example, the activities of daily living, like brushing, bathing, even the complex activities of daily living is essentially retained. So this is the right time actually you can intervene. There is no pharmacotherapy suggested. The guidelines, some guidelines will say that you can give a trial, but you have to discuss with the patient whether they are ready for that. So this is the situation, it's a pre-dementia kind of syndrome. So at that point of time, there is a big question as to how you can improve the cognition. Now, mild cognitive impairment is a very fluctual, or it's not a very concrete concept. It can actually kind of be quite fluctuant, and it can revert back as well. So it's told that 1/3 of the MCI actually remains stable, which we know as stable MCI. 1/3 of them progress to dementia or related disorders, and 1/3 of them actually reverts back in the normal context. So that's the situation. But here is a patient who is having a lot of comorbidities, the vascular comorbid burden like diabetes, hypertension, dyslipidemia. So when you actually correct all these things, it is very well possible that the person will have more chances of reverting back to normal. So that is something with respect to MCI. Even before MCI, just to add, because this is a very curious and enthusiastic group, something known as subjective cognitive decline. So where you yourself feel that compared to your baseline, you are actually having a memory decline. But your family members, for example, your wife or husband or your children or your other relatives do not feel you are absolutely normal, there is nothing. So that is something which can even precede MCI. It is not always that SCD will lead to MCI and then MCI to dementia. It can be either or any of the combinations, but it's always better to keep a lookout for MCI. And at CPR, the main mission is, because we are having a lot of longitudinal aging cohorts, both the urban and the rural. One of the key work that we do is to identify people with MCI and looking at tools and screening, either by blood biomarkers, to identify MCI early, and also to look at how we can intervene. These are some aspects.
Sure. Just to summarize in one line of what Dr. Thomas said, is MCI is something, it's mild, it's under the radar. Somebody must be just keeping above the water, managing it. Some crisis will sort of precipitate it. So, but the good thing is that if you identify it, you can work on it. Some of them can be stable. You can prevent them getting worsened and work on the other vascular risk factors. So, Jonas, we'll just say, you mentioned about, doctor, I've been forgetting names. I do have a blonde moment where I just don't figure out what things. Am I getting dementia? That's a common question that. So, Jonas, tell me, how do we go about this?
Sure. Thank you for the question. I think that's something very relevant. So, firstly, one is, in addition to the subjective complaints which a person can have, if there are objectively identifiable cognitive impairment, which is done usually through, these cognitive test batteries or neuropsychological tests which are being administered. The second important thing is how much of that memory disturbance is actually affecting we have some sort of management strategies and some sort of disease modifying drugs which are emerging, but I think the key remains in the early diagnosis. So my opinion would be that if anybody feels that there is a significant, and I think the individual is the best person to judge that. So if they feel that there is some significant memory or any other impairment in their thinking, because dementia is not just about the memory faculty alone, it can be also affecting their language abilities, their thinking and reasoning abilities, their judgment capabilities. So if somebody feels that any of these faculties are sort of deteriorating from what they have been functioning before, and that is particularly causing some sort of a disturbance in their functioning. For example, they're not able to maintain their, they're finding it difficult to maintain their finances, or they're finding it difficult to drive, or they're having difficulty in engaging in a conversation where they keep repeatedly forgetting about, the names or whatever. I think those are red flags, and they should, opt for early cognitive screening and then early diagnosis. I think that's the key.
Thank you, gentlemen. I think you highlight the most important thing is when you find that you're not socially functioning well, things are not so good, it's always good to get it checked and assessed with a screening test. So, Steve, you're a geriatrician in Apollo Hospital. Here is a 60-year-old lady who was a teacher, now retired, and she has a uncle who's got dementia, and she's not sure the father would have dementia because he had illness and he died. So she wants to know, how do I maintain myself well so that I reduce my chance of dementia? She's got diabetes, hypertension. So how would you go about encouraging her or educating her or instructing her in managing the condition so that you mitigate the side effect or the effect of developing dementia?
Thank you, Dr. Ivory. So in this case, this lady is protected by the fact that she is educated. Amongst the various 7 or 12 risk factors are diagnosed as per the Lancet Commission, education is very important. So the fact that she is educated protects her health. But the attention and probably isolation. Probably worsen. We are doing Bangalore, like places. They should be in a crowd. Use yourself in group activities. So this risk is mitigated.
Sure. Thank you. Thank you, Steve. I think that's very, you added the points about having a purpose and moving forward. And by the way, retire is spelled as not R-E-T-I-R-E, it is R-E-T-Y-R-E. You just retire and just get on with it. Dr. Girish, coming with the same lady, she comes to me and says, look, I'm 60 plus, I just retired now, and I'm really, my relationship with my spouse is more transactional. I had to move into a new apartment complex, which I'm not familiar with. I'm going through a certain sense of loneliness, and I'm not sure whether I'm downcast. Doctor, can you just help me? How do I figure things up, and how do I develop a purpose and things like that? So how do you approach that?
Okay. Before I start, Mrs. Ramani, thanks for swapping me into the session, and then.
Our pleasure that you're here.
See, there are three. Okay, let me diverge a bit and then come back. So most of the time we are talking about primary care, secondary care, and tertiary care, and that's where we're bringing in a component of prevention. Okay, can you hear now? Care, secondary care, and tertiary care. And somewhere we bring in the concept of prevention, saying that, okay, we prevent something going into secondary care, we prevent something going into tertiary care. But there is two other levels which we need to be looking at much more actively. That is community informal care and self-care. Now I think this lady who is looking at it needs to be aware that there is this component of self-care, wherein she can do a whole lot of things, which it is possible. Okay, let's take the issue in terms of that depression element which could get in. Now, how could she engage with others? Now, asking her to engage with others is the easiest thing.
Yeah.
But trying to find a mechanism wherein these systems exist is another important. When you were saying that, okay, there are elderly associations, but to what extent would they be able to reach out to as many individuals as possible? Those are the issues. When you said transactional with her husband, I think there is also a transaction which needs to happen within the community. Now that is where we need to build up systems. That is where she needs to take that proactive effort. Plus also the system needs to come in, wherein this sort of engagement places, a public space apart from their internal home environment can be set up. I think that becomes crucial and critical. Second, okay, there is also this issue of being engaged in exercise. Now, exercise in that sense seems to be a big stress buster. It's a pathway for us which opens up to a whole lot of interventions which is possible. Okay, I have got a doubt, I need to talk to someone. Okay, as part of that group walking, that is where that social interaction will happen. So in that sense, one, she need to start slowly getting into a physical activity. So that physical activity, not just alone, she could form a group, or she could get people who could be part of it. And then probably the apartment or wherever she is staying, there is a group which could get formed. Not just an elderly home or somewhere else. There is always a look at it people look at it in a different way, but looking at it in a very normal, regular household circumstances, I think there is a give and take which should happen between both of them. So again, to summarize back, self-care and that community informal care systems, both of them have to kick in.
Sure.
And then it's not just trying to give her some advice, but I think all of us can make these things happen. Now that's where is the beauty of it.
Sure. I think that you touched on a very important aspect about it. And unfortunately, the human tendency is birds with feathers will flock together, isn't it? People of like kind will always flock together. It takes an effort to go out of your comfort zone and mingle with people. And also, add to what Dr. Giri said, I mentioned a relationship with the husband is transactional. I want her to live in a home, not a house. And many times, they live in the same house, they don't even know what's happening to one another. It's so important that they develop the warmth of a relationship and break the barriers. And a lot of people have baggages that they're not dealt with. And a lot of spouses don't have that communal relationship. It's more a transactional relationship. And it's so important that they deal with it. Okay, now, Girish, I'll stay with you. The consortium study showed that risk factors for India is, which thing is women, less education, rural areas. So tell me what DIA can do, or what we all can do, we all part of DIA, all of us can do to help and see how we can bring about a change.
Okay, let me give one example.
Concrete examples, yeah.
Yeah, concrete example. This is more in urban area.
Yeah.
Which this is in the Baswanagudi area. Mr. Shikala Bharat Madam also was there. He started what is called as a Walking Plus program. It's a regular park. We said, okay, all of you come for a walk. Add something, 10 minutes extra exercise so that your muscle strengthening can happen. This Walking Plus program over a period of time became so very bonding between them so that it could address these three issues what you brought in. Education, yes, education may not be only with respect to written, read, write and arithmetic. Now, how do we convert that education into something which gets into cognitive resilience or cognitive ability? Now, that's one thing what we need to focus on. Now, in this Walking Plus program, just that they could talk to each other, feel comfortable in terms of even discussing their family problems became sort of a focus for them, so that it became that they needed to meet. This has happened in an urban area. Okay, what could happen in a rural area? We're talking about women, we're talking about education. We need to see that, create opportunities for them to get together. Now, let me tell you on the lighter side. We had the Chief Minister of Karnataka come in for one of the programs. He said one of the cognitive enhancing abilities is to use the Rangoli, which they do often. Now, when I asked the Chief Minister, sir, can you just try this Rangoli? He said, no, that's ladies' thing. I would. No, that is the sort of mindset we have. Shift back to Dalasnur, where CBR has got a running cohort project. We asked the same thing, will the gentlemen who are there participate in this Rangoli competition? They said, no, this is all ladies' work, it is not up to us. So there are many of these barriers which are already existing, and we need to make use of those opportunities. Rather, I would say, missed opportunities. Now, that is when many of these risk factors do get addressed. Now, that supporting each other, which is required, especially women, they do have that forum, but somewhere we tend to stigmatize it, we tend to brand it, we tend to label it. I think we need to look at it in a different mode, so that the existing systems which are there, for example, having competitions, so that they could get together. They may not do that on a daily basis, but at least that will bring people together, that will make them interact. So many of the risk factors what we are talking about, many of the information what they would like to see, many of the exchanges which would happen, which would be partly, there could be a lot of fights also. I'm sure I consider fights between individuals as a healthy way of agreeing to disagree or disagreeing on the disagreement. So let's take it very enthusiastically, energetically, and proactively, saying that okay, there may be differences, but at least you get together. Have these sort of good activities which would
so just
promote it.
Be connected to wherever you are. There's a laughing group in RT Nagar, a fantastic bunch of people. I think Dr. Girish brought out something very important. It's about the gender stereotypes. You know what? Sorry, you may not like me what I say now. The reason why a lot of men are miserable is that they're just not understood or being taught how to express, how to be empathetic, how to be emotional. And we tell a child, oh, you're a boy, why are you crying? How can you cry when you're a boy? You know what I mean? We put these gender stereotypes and things like that. Now the question to you, Thomas, I think I'll set the question to you. Now tell me how depression and dementia, it can be quite an entanglement. So how do you disentangle them? And what are the risk factors for patients with depression, developing dementia? And what can we do practically to people saying that, look, I had a history of dementia in the past, will it predispose me to things, and I leave it to you to think.
Thank you for that question. I think that's a very important point. Depression is something which is very under-recognized. And it seems that both depression and dementia have a bi-directional relationship. So if you have depression, you are at a lot of risk. That is, people are telling it's 8 to 9 times higher risk of you for developing a dementia. And if you are having early forms of dementia or early stages of dementia, you're also likely to develop depression, even with dementia. So that's something which we have to look. Now the Lancet commissions in the 2024 paper, so they have actually brought up 14 risk factors, looking at which contribute to 45%. So these are modifiable risk factors, and if you actually work on these risk factors, you can reduce the prevalence of dementia by 45%. That's what is the thought. And further, I think they want to make it somewhere that dementia is kind of a both preventable and modifiable kind of a disorder. So if you see in that, the midlife is defined, that's a very good news actually. So midlife in Lancet commissions is defined as some between 18 to 65 years of age. So I think we are a bunch of middle-aged people here. So yeah, so 18 to 65 years, just look at it. So, and the 10 risk factors, of which depression and hearing loss, I think depression is the question which was asked, is contributing about 7%. So that's not a small percentage if you actually see. So you can actually reduce depression and in turn prevent depression. So that's the learning. Now if you look at depression, most of the risk factors for depression, which could be social deprivation, or which could be social isolation, or which could be some emptiness kind of syndrome, which for the progressive depression, use of certain drugs for hypertension, multiple drugs which can interact together, you can so all this kind of mixopathies or whatever, all in the Indian context can lead on to depression. But most importantly, there is an element of what is known as vascular depression. Very under-recognized, very less seen. So if you look at the vascular risk factors like diabetes, hypertension, dyslipidemia, and all this metabolic syndrome related aspects, all this can lead to lot of white matter changes in the brain. Usually it was all dismissed like it's absolutely okay, it's with age, it's normal and all that. I'm not here to pathologize that. Yeah, you should not give a lot of catastrophic kind of representation to these small findings. But ultimately, this can all lead to lot of apathy, reduced interest, immotivation, and all that. The most important aspect with depression in elderly is that it is not typical, like a young onset depression. They will have lot of atypical features. They may sleep more, or they may be more tired to the entire day. They may be eating more. Usually in depression, people tend to avoid all this, rather than a typical anhedonia or a persistent kind of low mood, pervasive low mood over 2 weeks. So we have to actually see, I think, as gatekeepers for dementia prevention, people, all of us should be able to recognize features of depression among our friends, relatives, and colleagues. So that's something very important. So if you can actually see, okay, the person is having a low mood, long time, slightly less reactive, disinterested in activities, there's a family situation or there's a family life event, which maybe grief or bereavement, something. I think that's where you have to take it up, take them to the nearest qualified health professional, get them treated, because that may prevent them developing dementia in the long run.
Sure, thank you. To add something, I see a lot of my patients who come to me are from the stratosphere of where we are now. They have everything to live with. They have a shop to drive them around, they have fridge loaded with food and bank with a lot of money. They have everything to live with. But most of them have nothing to live for. And that's not a good place to be. You know? So I think it's so very important that we have a purpose, a motive to live for. I think that really mitigates. And as Dr. Thomas mentioned very clearly, we need to tease out the depression and dementia. We need to be very mindful about patient being downcast and having depression. And there is social stigma to see a psychiatrist and see a psychologist. I think we need to get over it. Dr. Jonas, the other thing which is a stigma here is hearing. You know what, so many people are so obstinate, to be honest with you, to accept that they have a hearing loss. So, and also vision is one of the new risk factors added. So tell me, how do you navigate, and tell me, shed some light, why it is so important for all of us to know that hearing is one of the major risk factors for dementia, and how do you encourage us and how do you lead us? So just give us some.
Sure. So I think you've highlighted one of the very relevant, but unfortunately very under-recognized risk factors of dementia. When people generally think of risk factors for dementia, I don't think sensory impairments like hearing impairment or vision impairment come to the forefront. But however, I think like some of the speakers have mentioned, now hearing impairment and sensory impairment have been placed in, and vision impairment have been placed in the list of this 14 modifiable risk factors for dementia. Now there are several ways in which hearing and visual impairment can potentially, be a predisposing factor or even a precipitating factor for developing cognitive impairment. Now, as we all know, hearing impairment, people with hearing impairment, the chances or, like you said, there's a stigma about getting diagnosed, getting appropriate help. So very often what people tend to do is they kind of tend to sort of go into a phase of helplessness, and then accept that, no, that's how it's going to be. With old age, I'm going to lose my hearing. With old age, I'm going to lose my vision. And they often don't tend to take steps to correct it. Now, indirectly, what happens is that not just affects their hearing and visual impairment, their functioning, it also starts affecting their social life as well. People start, withdrawing from conversations. People start, reducing the number of visits outside out of, fear of embarrassment or things like that. And then unfortunately, all this becomes a vicious cycle. And then this in turn affects cognition directly, indirectly through, decreased social interactions, higher risk of depression, and then ultimately it all results in a bad mix of high risk, which can actually put you at higher risk for cognitive impairment.
Yeah, it also predisposes them to fall, you have vision problem. My sincere request and plea to you all is that if you have a hearing impairment, make sure that you get it tested and be much more open-minded about having hearing aid. But a lot of people complain that there's so much of background noise, it does not fit well, but there are good companies which sort of look into that. So, Steve, you're a geriatrician and you get complicated patients. And this is a 75-year-old gentleman who's got kidney impairment, chronic kidney disease. He's got a heart disease, he's got a couple of stents, he's got poorly controlled diabetes. He's had a fall and his memory is fading. And you know that he's totally on his feet. So tell me, how do you work with such a patient? It is complicated. And how do you help the family to get the best for him and help us to do the best for him and optimize him?
Optimize him in terms of cognition.
Cardiovascular risk practice, principally working on cardiovascular risk practice.
So here, this reminds me of a situation at home, to be frank. So there are a lot of medical issues here. The patient has got cardiovascular risk factors, he's got chronic kidney disease.
Yeah.
And with risk factors of medical diseases itself, this itself pushes patients into depression. The very fact that there's a lot of health care burden, requirement to go to the hospital frequently, multiple admissions maybe, puts them into a state of, as you said earlier, no purpose in life. So I'm just leaving to go to hospitals. So that's one reason where his cognition can worsen. Second, with more hospital visits and community visits, he is again isolated. There's no activity, there's hardly anyone coming. The only person who comes and speaks to him is a nurse probably. And with the nuclear family size that we see nowadays, with poor social support, all this just worsens. You also mentioned he's
totally on his feet,
totally on his feet, and he's likely to fall. He's had a fall in the past. He can fall again with this multiple illnesses, medications, diuretics, all put him at risk of falls. And each fall, if a traumatic brain injury is caused, that's a significant risk factor. A traumatic brain injury, major traumatic brain injury like a bleed in the brain or any SH will increase the risk manifold for dementia. So here what needs to be done is correct the medical factors or optimize rather, there's no correction of it. Optimize, remove all the unnecessary medications that can predispose him to a fall. We often tend to think treating an older person is like treating an adult who's old. It's not the same. With age, many relaxations come in place. Like for example, blood pressure need not be kept at 120/80. There are pluses and minuses. You look at the risks versus benefits of any therapy, of any medication. Each medication, if added, can cause a side effect. You need to discuss this with him and with the patient's family. And optimize medications such as medical conditions are manageable, if not cured. Discuss and try and be proactive in estimating when would be the next hospital-based event, what complications are likely to occur. Discuss with the family and kind of explain to them the trajectory that where the patient is going, so they're prepared for what's ahead. Try and correct all factors that can predispose him to have a fall, and try and work up for other conditions that can be corrected, like an osteoporotic fracture, for example. These are the medical conditions that need to be solved or discussed. Involve family in decision making. Get the children, because often children are away. They do not know what's happening to dad or mom. They just keep coming and they just know he's hospitalized. Involve them in discussions, maybe over a phone call, or maybe ask them to visit you next time they come, and tell them where things are headed and what's the likely scenario going to be in the very near future. and often the decision should involve the patient himself. He needs to know what he is expected to do or what therapies he can be done. I recently had a patient, a 93-year-old man, who came with hyponatremia, low sodium. And in the course of a general evaluation, it was found that his aortic valve was very narrow in size. Immediately, a team of doctors came from various places suggesting the need for a aortic valve replacement. And this is a very safe procedure for a valve replacement, but instead of immediately opening the gateways for all those, my point would be to discuss with the family, discuss with the patient, find out how much of these symptoms are affecting his daily life routine before we subject him to a surgery. Because the benefit of the surgery may not necessarily translate into good quality of life. So these factors have to be modulated before we describe any treatment protocol. Advocate for the best level of physical activity. His medical conditions may not permit him to do physical activity in the best possible way. But advocate for this and involve the family decision making so that they know what is ahead and we mitigate maximum risk factors and maximize the quality of life.
Thanks, Steve. I think you touched on all the things. And what Steve was just telling is this person is becoming frailer. So frailty is setting in. So optimize the condition. And I want to say something to you guys. Ram may not speak to Ramesh, Paul may not speak to Peter, Rahim may not speak to Rashid, but in the body, your heart talks to your lung and not to your. The reason why I'm telling you is that you go to a neurologist, he gives you a set of medicines. You go to a cardiologist, he gives you a set of medicines. They work in silos. They don't get connected. You see the patients on 3 multivitamins. These are called commode drugs. You don't absorb, it goes to the commode. By the way, most of the commodes are well vitaminized because most of them are things. And many times, tell your doctor to see whether they can prune the medication. One of the most important things in medicine, even if I cannot do good for you, I shouldn't do harm for you. And so many patients of mine, sorry to use this word, they're given poisons. That needs to be, and many times they get better. It is so important that we prune. And also Steve touched on a very important aspect about what we call it as California daughter syndrome or Calicut daughter syndrome or Cochin daughter syndrome. Basically what it is, a daughter, sorry, I don't want to be sexist here. A son or a daughter is living off. The reason more daughters are concerned than sons. Okay, they're concerned and say, look, do everything for my dad, do everything for my mom. Do this. They want to throw good money after bad. It's a sense of guilt that's coming out. Isn't it? Yes or no? Am I talking to yes? Okay. So many times, as Steve was said, the patient wouldn't go for a surgery and there is no need for it. I'm not going to treat numbers. I'm not going to treat a diagnosis on the echo. I'm going to treat the person. So I think, Dr. Girish, so you have a challenging now. Now you want to get a advanced directive. Now, how do you navigate? You use the D word. Oh my God! They just go. They're not even dying or dead. He said, look, I tell my patients, look, I tell the family, I'll be very surprised to see you for next Ugadi. I'll be surprised to see you because your conditions are like this. What is it you want? What is your wish? What is your bucket list that I can take? And you know what, believe? A lot of my patients say, I want to go meet a friend of mine, mend fences with him. Or I want to go to Banaras, that's my wish has been. Or meet a friend who not a relative. Not. So I prepare him for that, rather than them coming. So how do you navigate? And as a culture, tell me, how are we in terms of accepting death and dying, advanced directives? Can you just put some light into it?
Okay. Let me borrow what Dr. Thomas said. 18 to 65.
Correct.
He said it's middle-aged. I would say it's 18 to 65. Dr. Thomas said it's middle-aged as per, but I would say it's the middle age. I think we tend to get into a whole lot of behaviors, practices in that. The issue, what you said, I don't think we are prepared to accept death, or we are prepared to accept frailty, or we are prepared to accept the deficiencies which come with age. I think that's a bigger underlying thing. And we medical people at points of time have encouraged or saying that everything can be prevented. Why do you bother about it? Okay, this is so that's where is also the part of the problem. So you can't just isolate it and then say, okay, you you tell me your bucket list and what. Yeah, but that has to go through a process. It cannot just be given on one day. And I'm sure a confidant in the guise of a physician, a confidant in the guise of a friend, will be in a better position to communicate these sort of messages. Surprisingly so, I know there are several things which come up, but several of my family members at some point of time, or people whom I talk to, they are open, but there is still that lingering doubt that can something else happen? Is there a magic remedy? It's not just that Calicut, Cochin, California children coming in, but it's also that who will take that decision? How do you go about
I think you hit the nail on the
communicating
head.
that?
You hit the nail on the head. Yeah.
That is where when I just wanted to interject earlier. In one of the senior citizens forum, I was asked to give a talk. I was as usual, I think I can get in some slides about dementia, prevention, risk factor, Lancet Commission. I can throw in a lot of words, but I wasn't comfortable, and then finally, at the spur of the moment, I had all the slides set, but after looking at the audience, I said I will junk all that, and then, sorry about this, junk all that, and then on the spur of the moment, I brought in 2 groups from the audience so that they do a role play in terms of communicating with people. That created that magic. Highly trained professor, he felt that he knows everything about dementia. He could rattle out all these risk factors, all these things. But talking to another, his supposed friend, as part of role play, he couldn't even give that empathetic response. Now, I thought that's a thing which possibly we need to practice. We need to develop skills. How do I respond? If a friend says, okay, my term is just about 6 months or to a year, how do I respond to that? It's a difficult thing. We are not taught, neither are the medical people nor as a general public we are aware about it. But that doesn't stop us from experimenting. I think that experimenting should start. I would request each one of you, please, let's learn that skill of how we can support each other. That's very critical and crucial. Possibly, I would push the dying declaration to one step later. Let me give a personal example. My children, in that sense, one of my uncles from US, every year updates his will and then sends it to me. He says that I am the person who is in charge of his health will. My children laugh. My father, who is 90-year-old, says, why do you want to have all that? So it's also that cultural context. I think we need to change, but let's start experimenting. We will make mistakes, but let's start talking. Let's start talking that these are the realities of life. Vanaprastha is not some alien concept, but also that's not a romanticizing concept.
Sure.
Something needs to be more realistic in our context. As you rightly said, possibly going to a religious place, or even just having a meal with someone else, or just leave me alone also could be a thing. But
it is extremely challenging to.
Hope I answered your.
No, absolutely. You touched a lot of important points. I just want to say this to the audience here. I want a show of hands. How many of you have one physician that you go to work as a anchor for you to get referred? How many people have a confidant physician? Sure. Thank you. It's minority, but it's not bad. But I would say one thing to you, gentlemen. My discussion with my patients about death and dying doesn't come in one visit, as Dr. Giri said. We have known each other for years and years and years. And he has that liberty and the confidence to express to me so that I know what's going on with him. And he will tell me what's going on. And we catch it. So it's so important that you have one physician that you trust, that you can anchor that person, and he can refer to a neurologist or cardiologist and whatever it is, and bring you back and sort of join the dots together. The problem is this: we all work in silos and we are not joining the dots. A lot of people are getting medicines they shouldn't be getting, and it is so important that we think. And one more thing is, I'll tell you a sobering, sorry sir, yeah.
With your permission.
Yes please, yeah.
May I refer all of you? Sorry. Sorry to pardon.
My pleasure sir, yes.
With your permission, may I refer all of you to this article which came last Saturday in the Deccan Herald. It was the Saturday page of Deccan Herald. It was written by a doctor called Dr. B.C. Rao. And he is talking exactly of what you are talking about now. Or what having got, because he is one such person. He is 85 plus now. He lives in Indira Nagar. Kindly go and read the article.
Sure.
It is there last. It's exactly what you are saying now.
Thank you gentlemen for shedding the light there. Thank you. You're spot on. Now, I'll tell you a sobering statistics. Okay? You go to any ICU, 75% of the people are people about 70 to 80 years in the ICU. The system, medical system in India is made in such a way. I'm not making a judgment about it. I'm telling the facts to it. Whenever a person comes to emergency who's unwell, they won't even have a cognitive exercise to check whether this person is fit for ICU. They just push him into ICU, shove the tubes in every possible orifice or create new orifice and push him there, and you strip them of dignity. ICU is both cold physically and metaphorically. And you know so many people dying without dignity. We have the children. I don't know. They don't, see, please don't let your children second guess. Now, I'll tell you to the younger people, how do you approach death and dying in this culture? When you go to a death ceremony or something, you ask, Dad, if such a thing happens to you, tell me how do I navigate? And that's the right context to ask. And you can hear a situation where somebody is going through cancer therapy. You know what, it's so distressing to see this person going through cancer therapy. And most of them don't even know that they're going to cancer therapy. You know? So how do you navigate? So you can always ask your parents without sort of upsetting them or hurting them, that how do I navigate? Because you're not second guessing. And a lot of them are driven by guilt. And let me say one more important statistics. Medical bankruptcy is very real in India. I know a lot of crorepathies becoming roadpathies. It doesn't take long. And that's the fact. Now, sorry.
Sorry if I can.
Yes, please.
Have one caveat.
Yeah.
Since we are talking about confidants, I'm sure we are all a bit selfish. We may not be happy with just one confidant. Probably
Sure,
2 to 3. I think that's more realistic.
Yes. That's okay.
I'm sure all of us recognize that. Please build your network so that that network will support you at every point of time.
Sure. I think we'll go through some other things. Sorry.
Question. Does hereditary has got a factor in dementia? And Dr. Pranay from aerospace.
Yeah, you just stole my words. You just told, you're such a clever man, you're telepathic. So tell me exactly that. That's hereditary. My uncle had this. So, and they go through extreme amount of anxiety, Dr. Thomas. And how do you navigate through this?
Yeah, everything is hereditary if you actually can tell it. But to assure everybody here, the primary genetic forms of dementia, the familial dementias that we tell, less than 5% from a monogenic cause of dementia. So it's not genes that matter. Obviously, there are some studies where ApoE4 protein, which is ApoE4 allele, apolipoprotein E4 allele, is supposed to have higher risk in dementia. But let me also tell you an interesting fact of ApoE4. ApoE4 increases the odds of developing dementia by about 9 times in the Caucasian population. In the African population, it is protective. And in India, it is actually, there is less studies to say that it's bad. When ApoE4 actually interacts, there has been a lot of work, Dr. Jonas also has worked on this. In CBR, we have looked at the role of apolipoprotein E4 or ApoE4 allele, and we identified that it doesn't act in isolation. If you are diabetic, if you are hypertensive, if you are having poor cholesterol levels, at that point of time, ApoE4 is kind of interacting in synergy.
Sure.
And your risk for dementia is there.
Do they need to check ApoE4? Hello, madam.
Not at all.
Not at all.
Yeah.
So I think, is there any blood test they can do to check whether they're developing dementia?
The best thing is to look at your sugars,
Yes.
your cholesterol, and your BP regularly. I think that would
Sure.
suffice. We are not at the stage of identifying precision medicine right now. So even if you have a gene for developing dementia, people with Down syndrome develop dementia because they have the APP gene, which they have an additional chromosome 21 there. But apart from that, what do this give you? You identify that you are prone to develop this disease. You will be more at risk for developing stress, anxiety, and depression rather than looking at therapies which may not be currently available.
Sure.
So the final point is, don't be concerned about hereditary.
Sure. And Jonas, I want to say, I know how to exercise my biceps. Tell me how do we all exercise all the tracts of the brain, and is cognitive stimulation test good for us? Is anything that we can do, Sudoku or something to sort of encourage a cognitive reserve? How do we do that?
Sure. So I think like exercise, physical exercises to the heart, mental and cognitive activity and stimulating activities is to the brain. And I think the brain pretty much functions on the principle of use or lose. So I think it's very, very important. And I think particularly we've seen even in our own research that people, especially after they retire, there is a very sharp decline in their cognitive activity. Cognitive, physical, social, mental. So I think it's very, very important to keep ourselves cognitively active. Now, there is no one prescription to all saying do this, do Sudoku or do whatever. But I think it's very important to, enhance probably what you've been doing before. It's not a bad idea to learn something new. For example, we've shown in our research that learning a new language is definitely associated with better cognitive performance and even better brain volumes. So learn a new language, learn a new hobby, keep yourself cognitively engaged in whatever way. And I would like to second what I think Dr. Dominic said, what Dr. Giri said, that watching TV is definitely not cognitively stimulating. I think what is important is to keep yourself engaged. Not just passively be, see, even with regards to, social stimulation, I just want to add on, because it's in the same lines, that it's not just about having a big social network. I think it's very important how engaged you are in the social network and how diverse your network is. So the same goes with cognitive stimulating activities. Now, if I want to go a step further and just also touch upon the fact, there are also certain specific cognitive stimulating, activity modules, actually many of which have been researched well. It's not as popular in India as it is in the West, but I think it's definitely coming up. So I think people engaging in those activities, but I think at least for the basic level, keeping yourself cognitively engaged in whatever you've done, trying to learn something new, even learning a new musical thing. There's no age for saying that it's too late. We've shown, I think Thomas in one of his research showed that people who practice or learn Carnatic music have bigger brain volumes in the areas which are responsible for dementia risk. So I think any form of cognitive stimulation, particularly if it is done in a more structured way, either done it through a module or done through an app or anything like that, I think that's definitely going to help.
And Steve, important question for you. A lot of people have delirium and dementia. So in few words, I know you're a clever man, you can articulate. How do you tease it out? And because they're...
Thank you for bringing this up. So delirium is a state of altered mental state. It's an acute confusional state that happens usually in patients with hospitalization or during an acute illness. Most of you would have come across this scenario. I think she's developing dementia. While she was in the hospital, she was rattling out some confused conversations. And often that's still happening at home. But then she becomes okay by evening. This fluctuant nature of this confusional state is usually in the setting of an infection, sometimes medicines, is what we call as delirium. Now, delirium is linked to dementia. So patients, there have been studies that have shown that delirium, patients with delirium most likely will develop dementia in the future. And vice versa too. Patients with dementia are known to have delirium. So hospitalization, during hospitals, delirium is very frequent. I think the numbers, however high they are the underestimation of what exactly it is. hospital ICUs are the worst place to be in patients who are likely to develop delirium. And the shorter the stay, the better. You can send sometimes when the patient on day 2 starts to talk strangely. That's the trigger point, you have to shift the patient out of ICU immediately, or the next day could be even worse. Because delirium makes the patient violent, obtrusive to any management. Sedatives are added, and this worsens the whole hospital decline also worsens. So it's important to diagnose delirium, separate them from dementia, and because with dementia there's a lot of stigma. Once a patient shows signs of delirium, often people mistake this as dementia, and dementia would be branded. And once dementia, anything and everything is attributed to dementia, in this country at least. So we need to be very careful and tease out the delirium from dementia.
The other risk factors are traumatic brain injury. Yes, gentlemen. Yes. I think we have a lot, sleep, diet. I'm not sure how much you have time. We are running out of time.
Another 2 minutes.
Another 2 minutes. Oh, okay. I need to. We'll take the questions. We'll be around, and then I want to close. Oh, there are questions. There are questions still.
So if you have questions, we have a separate Q&A session from 12:30 to 1.
Oh,
so
okay.
if you have questions, write them down. Our panelists will still be here. We can ask the questions again.
So I'll leave you on a positive note. There are 2 studies I want you to go and look at it. It's very easy to read. One is called a NUN study. It was a study done way back in late 1979 from Minnesota and moved it to Texas. What did the study show? Even when people have a pathology, brain pathology in postmortem with dementia, they never manifested dementia. If people are being cheerful, happy, exuberant, vivacious, spirited people. NUN. Okay? So what am I trying to tell you? Your brain has got a lot of reserve to play with. It's an amazing creation of God, and use it to the full. The second study is a very profound study. It's called Grant and Gulick study. Okay? This is a study which was done started from 1945. It's the longest prospective study in the world. And CNN will not tell you, BBC will not tell you, because it's exactly antithesis to what they believe in. What they wanted to find out is, does money, does fame give you happiness? Okay? So they recruited people from Harvard, the most elite, and also Irish boys who were immigrants who came to Boston. And they studied them for 75 years, ladies and gentlemen. And the participant believed that money and fame will give them happiness. The investigators believed that the fame and happiness will give you, fame and money will give you happiness. But what they found was so shocking. They used to meet these clients every 2 years, spend a couple of days with them. John F. Kennedy was part of the study. One of them went on to become the president, but a lot of them went downhill, whom they thought was very clever. What they found out is this: at your 50, it is not your bank balance or your lipid levels that decides how you live your life. What decides how you live your life is relationship, relationship, relationship. So it's so important that we give value to our relationship, be it a spouse at home, your friend in your neighborhood, or your colleague or confidant or whatever it is. It is relationship, relationship. That's what makes us not to be a hurtful person, helpful person. Not to be a hateful person, but a grateful person. Then you won't be a whiner, you'll be a winner. You'll be more a blessing person. You know what I mean to say? Aging is not to be feared for. Aging has to be confronted. Aging has to be dealt with. There's so much of negative stigma about aging. Aging is such a wonderful thing. You carry a wealth of experience, but many people cannot enjoy the harvest of their labor because they are not in a good health. It is so important that as you advance in age, that you're not existing, you are living. It is not apples and pears comparison, it is chalk and cheese comparison. I want you to be living well, and living to the fullness of your life. For that, you need the master organ to work with you. So look after your brain, look after your health. And we looked at all the risk factors. There are so many things that we didn't look at. We look at the diet, the sleep, the whole lot of things. But you touch on the major things that we need to touch on. So we are most happy to answer any questions later on. And I just want to thank Dr. Thomas, Dr. Santos,
Sir, one question for the
Steve,
benefit
and Dr. Girish. Yeah.
for the benefit of the audience. See, I made a study in Delhi, All India Medical Sciences, New Delhi. Geriatric population took 60, 70, 80 years. Their ability to understand, even normal population should know that we use our perceptual ability about 20% at the age of 60, 70 about 30%. After 80 years, you lose your 40% of your memory and 40% of the concept. That's what I'm an audiologist basically. That's called auditory phonemic regression. That regression takes place after age 60, 70, 80. So that's why auditory perception, like hearing was asking about it, auditory perception also decreases. Have anybody studied on visual perception? How visual perception, visual ability decreases as they advance? I don't know when you study that.
Well, I think you touched on a very important topic, and what we know is that people who have a right brain strokes, the way they look at the world changes. In fact, people say people who have a right brain strokes are much more disadvantaged than left brain stroke. I think that's a totally new topic, and thanks for highlighting what you said. I mean, thanks for the work you've done. You've been such a blessing. Yes, auditory is such a thing that we talked about, and we also talked about how people are obstinate not to come to terms that they have a problem with hearing. Okay, so we have a lot of questions. Thank God that we have. Of course, we have a change in perspective. I strongly believe. I think all the panelists believe that there is a lot of force for good. There's a lot of force for change, and our brain is very plastic and adaptable. There's so much that we don't know and so much that we don't use. So I think it's wonderful, isn't it? There's a mystery and mystical about it, and that's what makes it beautiful. Yes, Dr. Krish.
Just a quick rebuttal to what you said. I think one of the recent WHO document talks about the capability rather than these physiological, what you can say, reductions which would happen.
Yeah.
So I think we need to talk about that. I think that's more in the question answer session. As we age,
yeah,
there is a greater efficiency which would also come, and let's be also mindful of it.
Thank you.
Sure, thanks. I think we need to be mindful about the time, and thank you. Thank you.
Thank you, Dr. Dominic, Dr. Thomas, Dr. Jonas, Dr. Steve, and Dr. Girish. Please put your hands together. Thank you. We extend a warm welcome to Dr. Radha S. Murthy, the co-founder of Dementia India Alliance, the president of Dementia India Alliance. Thank you, ma'am, for taking time from your schedule to be here. It's my pleasure now to introduce and welcome Thomas Isaac, a dynamic entrepreneur and passionate advocate for brain health. He's the founder of Ivory, and Ivory and Dementia India Alliance are conducting this program together. This is a pioneering platform focused on adult-centered cognitive assessments and personalized brain health solutions. He and his clinical team are making cognitive care accessible, proactive, and impactful. Before starting Ivory, Isaac held leadership roles in renowned organizations such as Discovery, Healthify Me, and Puma, where he brought innovation and strategic thinking to the forefront. He's also a published author with Penguin and HarperCollins, so it's a pleasure for us to have Isaac with us this morning. Ivory and the Dementia India Alliance are embarking on a new program, and I think Isaac's going to make that important announcement now. Please put your hands together for Isaac.
Thank you, everyone, and good morning. It feels like we are stepping into pretty wide shoes to fill with that fantastic moderation by Dr. Dominic and the panelists we've had here before. I want to just actually start off from where Dr. Dominic left. He called the brain the master organ, and here's a question from all of you. All of you, which particular organ expends maximum energy during a day? Brain. Can you give me a percentage? And think of all the organs that are there in your body, right? So here are 5 ranges. Is it 5 to 10%? Is it 10 to 15%? Or is it 20 to 25%? Daily calorie consumption expenditure. The master organ, right? We've all established it's the brain. So any answers? I'm taking all 3 options. 10 to 15 is a good guess. 20 to 25 is a smart guess. So it is 20 to 25%. It is a trick question. We are talking about, the master organ. Now, the next question for all of you. I'm almost certain 100% of you took an annual body health checkup in the last 6 to 12 months. Is that fair? Is there anybody who did not take? See, not a single, maybe 1% or 2%, right? A real minority. All of you took an annual body health checkup. We just said that the master organ is the brain. Did you all do a cognitive assessment? Very happy to see that, sir. Very happy to see that. Lovely. So that's exactly what Ivory does. We help drive cognitive assessments for you, and our mission as a company is to help drive this cognitive testing at scale, because the one thing that all the panelists have told us is that early detection is key. The sooner you detect something, the more you'll be able to act on it and prevent further risk of dementia. Me and my co-founder, we founded this company from a couple of personal experiences. My co-founder's grandmother had dementia, my father had Parkinson's. So I have seen what having no right medication does to a particular family, and that was the reason why we entered this space. So that's all that I want to share about Ivory today. I do want to ask here, how many of you are already a caregiver for a potentially affected person? I see one hand there, a few hands there. And as, thank you for sharing, and as Ivory went into this journey of driving cognitive assessment, more and more people came to us. And Dr. Thomas talked about it, right? There is a hereditary risk. So people who are going through, let's say, or have seen, dementia in their family have slightly greater risk. And they come to us to get their cognitive assessment done. And we always tell them there are 90-95% of things that are actually within your control. Your genes, of course, you can't change, but there are things that you can do in terms of the risk factors that we spoke about. However, Ivory kept getting questions about what they can do as caregiver to be educated better about how to take care of their loved one, what they can do to address certain situations which become very exigent and immediate. And in 90% of the cases, we used to divert those questions to Dementia India's very proactive helpline. Like our team members have proactively called and put people in touch. And touchwood, it's such a great service that a country like India needs, which is going to face potentially a dementia crisis in the coming years. But alongside it, people also wanted emotional support, people also wanted additional tools and resources, and they wanted to take care of themselves as well. So caregiver burden is also a real thing, caregiver stress is a real thing, caregiver burnout is a real thing. And that's please feel free to collect this card. It's a very simple card. You can scan your QR code. I think Bangalore is anyway on an average more tech savvy than the rest of the nation, so we are not giving out physical brochures. But please feel free to register here. You can scan the QR code. With that, very excited to move on to the next session that we have. I'm going to take 30 seconds to introduce my very esteemed panelists, and I want to begin with Dr. Shrikala Bharat, who is the former professor of psychiatry at NIMHANS Bangalore and presently in private practice specializing in adult and old age psychiatry. She's also affiliated with multiple organizations such as Nightingale's Medical Trust, Dementia India Alliance, Step for Wellbeing Initiative, and the Sumana Trust. Next, Dr. Pritesh Kiran, currently Associate Professor, Department of Community Health at St. John's Medical College. Comes with a prolific track record of having been published in over 50 national and international journals and multiple-time COVID Warrior Award. Ms. Ramani Sundaram, Executive Director, Dementia India Alliance, a neuroscientist, a caregiver, and as we know, Dementia India Alliance is one of the leading voices today in the space of both prevention and caregiving for dementia. And last but not the least, Ms. Jwala Narayanan, consultant neuropsychologist with Manipal Hospital and Annaswamy Madhurya General Hospital, and also lead neuropsychologist at Cognitive Neurology Clinic. I've also had the pleasure of being in Jwala's clinic and seeing how much her patients actually dote on her and her team. So have some personal window there. So with that, we will move on to the panel and the questions. So we've all heard these official introductions, but as we know, cognition affects memory, right? So I want to know all of you through the lens of a favorite childhood memory that you can share. with the audience, just so that we know you a little bit better as people also. A favorite childhood memory which you haven't forgotten yet, obviously.
So you mean a favorite one? I
Yes.
can remember the one which affected you the most.
Yeah.
So I remember the first day at there was nothing like a preschool or anything, but I remember my kindergarten. I was inside, I went inside, I saw some toys. It is not one of those fancy things, it was a very, very simple thing. Then I suddenly turned and I saw that my mother was not there. That's something which I always remember, that they didn't even tell me that, they are going to leave me and go. So it really scared me that I have been, just abandoned and nobody is going to come back and take me home. So that I always remember even today.
But you can't leave us in suspense. What happened?
Yeah, after an hour my mother came and picked me up.
Okay.
So that was, I was very grateful.
Okay.
But I don't think I stopped crying for the next 1 hour.
Okay. All right. Yeah, Dr. Pritesh.
Well, I would probably look back on my grandparents, my mother's father and mother who are no more. But my grandmother who used to actually prepare a wonderful sweet called mani. Right? I miss that a lot because I think nobody has picked up the skill of making it the way she used to do it. And the second bit was my grandfather, on a similar line of what ma'am said. He took me actually to kindergarten school on the first day. And I was cajoled, coaxed, he made me sit on his shoulders and took me out there. And finally when it actually came to leaving, I turned around and said, "Aren't you staying?" Right, so he looked at me with a smile and he said, "No, this is meant for children." So I said, "No, but you can stay back. I'm sure they'll like you staying back." And my memory is that he stayed back through that first day. And he spent time with the other children, I think, enjoying it the most, as much as possibly, I enjoyed that first day. So when they mentioned that when you actually become old, it's a second childhood, I think, that memory of him spending that day symbolified, that second childhood, that he brought out from him, from his, own heart, in terms of spending that day, at that kindergarten. So,
thank you for sharing that.
Thanks, Sir. My father was an army man, so we kept moving places every 3 years. So I think my memory as a child is that I think very early on in my life I learned that you should not get attached. Every 3 years you have to pack your bags and keep moving. So I think that's really something that has stayed with me. And I think another thing is, since we grew up in like an army household, we used to be taken to school in those army vans. And I used to always compare them with the vans that used to catch dogs, because it will have the same kind of doors, and we were not allowed to look outside at those things. So always when I used to go to school, other friends of mine used to say that I come in a dog catching vehicle. So that's going to stay with me.
I think mine's very similar to Ramani in some sense. So I lived most of my life in Bombay, but not anymore. Now I've been in Bangalore. But we moved houses, many houses. I've lived in over 40 places in Bombay. And I think that was one of my biggest learnings in childhood, is just to be flexible, to be open, make new friends, very carefree. And nothing really has to bind you in life. And I think that's my memory from childhood, is just to keep moving, keep adapting.
Thank you to everyone for sharing that. Now we see, I'm pretty sure all of you related to one of these stories or the other, right? When it's really like these memories which make us. And yet something as functional and simple as a cognitive screening today is not widely adopted at scale. I want to begin with perhaps Dr. Shrikala, just asking you from a clinical lens, what's probably one myth that you would like to bust about cognitive screening in professional settings that most people you've seen that need to get past?
I think I will start with your memory recall. So most of the people think, the children or the spouse or the siblings think, that if you can remember things which happened in your childhood and in 1947 or before 47 during the British time, that my father or mother or my brother or sister does not have dementia and doesn't need, they have such sharp memories and they can recite the whole of Vishnu Sahasranamam without looking at it, they don't have dementia. So that is the biggest myth. And if the sons or the daughters watch their mother give up slowly cooking or wearing a sari, they think that it is more related to aging rather than that they have difficulty in what we say. These are very, very functional aspect of what we say executive functions. That means there is a plan and you follow certain things in certain order, and there is already a plan in your mind. It may be an automatic one, but still there is a bit of your cerebral cortex which is involved. And so we forget these aspects of executive function and relate it more to aging. It could be aging, but there is a need to check. You know that most of the times you will lock the door, but still before retiring, you come and check the door, isn't it, of your house. So exactly like that, it may be just because of, somebody says, I don't care if I wear a nightie the whole day. Doesn't matter, but check. That is all we are saying, and don't assume.
Yeah. I have the same question for each of you actually, because you all come from such different perspectives, so Dr. Pritesh.
Right.
One myth.
So I think certainly like Dr. Shrikala said, as far as cognitive decline is concerned, it's looked at as a phenomenon of aging, right? But we need to remember that we need to pick it up early. The picking up of cognitive decline on an early basis, there is a lot of lack of awareness, especially in rural settings, right? So we have even this lack of awareness in urban settings in very educated households, wherein they just attribute it to something that is normal. We need to always remind all of our elderly as well as their families that cognitive decline can be addressed and reversed at certain times. That is the most important thing to remember. It is not something that will progressively go on and decline in the same way for everybody. There is a different trajectory for each person. And it is certain interventions that we can actually do in terms of the previous panel, what they did mention in terms of certain lifestyle modifications, certain changes, to be able to change the trajectory of cognitive decline. It's not that everybody has the same decline at the same rate. Different people exhibit different levels of decline, different rates of decline. And interventions on our part, not only from the medical teams, but also families and other support systems are very essential in terms of reversing or reducing the speed of decline of cognitive impairment.
We do a lot of work in the community, and one of the areas we look at is spreading awareness about dementia and also sort of taking up community screening. And the one thing that we do is first do the awareness program and then do the screening so that people are aware what actually we are doing. So for past 3-4 months, we've been actively doing community screening in Bangalore, and few of the things that we have noticed, especially one thing that especially surprised me was one particular senior citizen association we called, and we said we're from Dementia India Alliance and we want to come and talk about healthy aging. They said, can you not call yourself Dementia India Alliance because it's got dementia in it? Can you call yourself something else? So there is some sort of stigma that is attached to the D word. So, that is something that definitely needs a lot of work. And also when we go out to the community, when you say dementia awareness, people really don't want to attend. So we kind of talk about healthy aging, we talk about brain health and all of that. And also when we do the awareness program and we do talk about brain health, many people come up to me and ask, if dementia is not treatable, you're telling me it's not treatable. You do tell me there are risk factors, but you're not saying that 100% I will not get it, you can't tell me. Why I need to know? I don't want to know. So I don't want to get myself screened. Though we talk about early diagnosis, we say it's helpful and all of that, definitely there's a deep-rooted stigma in not wanting to know what lies beyond. So I think that's a big challenge.
I think what really surprises me when I see people coming into the clinic, firstly they come in so much later after seeing cognitive symptoms in their family. One is, like Dr. Shikhar Bharat said, that don't assume that it's part of normal aging. But another is, a lot of people think that any memory complaints or any cognitive problems in older age is neurodegenerative. But a lot of it can be reversible, and I think that's what we really need to bring out, spread more awareness on, is that all cognitive symptoms are not necessarily degenerative.
Got it. I'm picking up a few things from here. One is we spoke about signs, right? Some of these signs. Let's go a little deeper into what some of these signs could be for. And I want to come to you, Jwala, and then Dr. Yushrikla, which is to say that, and again, these can be so confusing. You can remember something from the past, like really well. You might not remember what happened, like let's say, half an hour ago. So what are some of the signs when people come to you and say that this is happening with my loved one? What signs for you are like absolutely telling ones wherein you think that this person needs immediate attention, and what are the signs in which you can say that actually this is not that concerning? Like, help us give some color on that.
Yeah, I think it's interesting. Again, I think in the last 15 years there's been a change. Before people would assume that memory problems is normal, and now people are very anxious. So when they come in, they do come in with a lot of memory complaints, and it can be repetitive questioning, doing the same thing again and again. Those are, if it is consistent, they are classic symptoms of memory problems. I think a lot of it that gets missed out is social withdrawal. So a lot of people think that it's just part of normal aging, that people stop talking or people don't communicate. So I think those are early signs that really stand out for me, saying that they've not been doing anything, they were a very social person, and now they're not talking, they're not going out to people, they don't want to go for weddings. So that's a big sign for us in the clinic. Another thing that a lot of the times get missed off is people who've been a certain personality, so they've always been giving, they've always been stubborn, they've always been a very difficult person, and that personality gets exaggerated. And that gets missed because they think, yeah, but this is dad or this is mom, always, that's her personality. So I think these are certain telltale signs that we're able to sort of pick up in the clinic, because we try and relate it to how is it affecting functioning, how is it affecting decision making. So I think those now come up much earlier than just memory.
Got it. And Dr. Shrikla, if you can throw light on some signs when people tell you that this is happening with me, because when we talk about prevention, we talk about risk reduction, let's also allay some fears today. Let's say that if you're facing, let's say, one or two of these things, it's probably nothing serious. You can go about your day-to-day lives.
So as a sort of a assuaging, the bomb on the thing, is many of us, I'm 70 years old, so many of us experience subjective memory loss. Okay, so you forget where you have kept your keys, or whether you have put salt in what you are preparing, and I said whether I have locked the door, or all these things. So after some time, after about 5 minutes, if you are able to retrace, where did I go? I went here, there, oh, I must have put the keys, or I have put my specs. I went to the toilet, I must have put it on top of the cupboard there. So if I am able to retrace and then find out, and I am very much aware of it, whether it is seen objectively by my spouse or my daughter, but I am able to retrace, I have the understanding that I have memory loss, and I am able to retrace it, then probably I am not having dementia, I am just aging. Okay, but on the other hand, I forget, and then my spouse or my daughter or my son says, Amma, you have forgotten. I say, actually I didn't forget. Actually I did it purposefully so that it will be safe there. I get into that mode, and they are observing that I am forgetting. Amma, you forgot to tell the news that somebody would be coming. I said that they told that probably, that's why I didn't pass on the message to you. Because they said probably, I didn't pass on the message. So everything becomes a negation of the memory deficits. Then definitely my daughter or my husband, whoever has to say, definitely this person needs much more attention. And the other thing this is something which mostly I say for people. And this is something can be done both by you if you are able to retrace, and the other people who are there who, if you do not understand, if the person doesn't remember, that they are forgetting. So these are two different things. And apart from all the other things what Dr. Jwala has said about the early things and recent memory deficits, forgetting names, which is again part of aging. So there is a lot of overlap. As somebody said, I think Dr. Dominic said, it's a good idea that nowadays you have so many online screening things also. So just do it or do a crossword puzzle and see whether you can solve it, if you are used to it, of course. I cannot ask a person who's not educated to do a crossword puzzle. But I'm sure every culture has some specific things which can show whether you are still able to do certain things which you did 10 years earlier. Not even talking about when you were 60, but about 5 years earlier or 10 years earlier. Just repeat it and see. Tell a recipe in the correct order and see whether you can do it.
To elaborate on what is retracing, see you forget something,
okay.
then you remember that you have forgotten. And you try to search. Does this involve retracing?
Yeah, so I will say that, okay, where did I keep my specs? I cannot see without my specs. So, where did I keep my specs? So before coming to the hall, what did I do? Did I go to the kitchen to drink a cup of water, or did I go to the toilet to wash my face and use the restroom? Could I have kept it there? Did I change my dress? So would I have put it in my cupboard? So if you are able to retrace what you did and then go and find your specs, probably I don't have dementia. I'm just either preoccupied or an absent-minded professor, that's why.
What if you have awareness of the memory loss, but you're not able to find it again?
I think you definitely, somebody needs cognitive screening. Yeah. See, many a times, what is cognitive screening? It just talks about your memory. Are you forgetting? I will give you 3 things to say, and can you remember it after about 10 minutes? After a lot of distraction. So what it does is, helps you to sort of hear, register, and then this is what we say as scrapbook memory. So when somebody tells you a phone number, nowadays you have cell phone, but earlier you used to say, let me take a pen and pencil. And then you'll take a pen and pencil, or you'll take a pen and then write it on your palm. And then once you have put it somewhere in your calendar or your address book, you will rub it off. So it's worth only that much. But you can retrieve it from the address book. That's what the brain does. It holds it for some time in the regular recent memory for some time, and then it puts it back. But you should be able to retrieve. I'm sure it is like our brain is a locker. You should be able to receive anytime, even if you have not opened your locker for about 5 years. So that is very important. So there is a recent memory, and then there is an engraved long-term memory.
You saw how, yeah, sorry.
And many a times we also talk about, where, when, how, what. And these are very important. So when you describe certain things, you went to the August 15th function, what happened there, who were there. So if you are able to say some of these things, then things are probably all right. Something which happened recently, we are not talking about when I fought the war in 1947 and when Jawaharlal Nehru was in the Red Fort. We are talking about the last August 15th. So
it depends upon your retention capacity, acquisition, your retention, and transfer effect. These 3 things have to take place in your brain.
Allow us 15 minutes. You saw how deep we have gone with just one question, right? And I'm sure you found it valuable. I do want to get into more topics with more depth, and we will keep time for questions. But thank you, Dr. Shrikal. I think this was probably the most encouraging. I'm sure I heard a few, let's give a round of applause for that question, because this is something that, and I want to point to what Ramani said as well, which is that before they do testing, awareness is important. If you know what to test for, or if you know what signs to test for, and I hope everyone takes that away today, that, at least at a very bare level, I know this is a sign that, I should probably consider it seriously. I think this would be like a great value of our time. Dr. Pradesh, I want to come to you. You said something about timing, that, you should, like when they should go and get tested. Let's talk about what's a good time, and maybe it is different from urban audiences, different from rural audiences. You work with such a wide variety of people within the community health drives that you do. What have been some of your insights as to when is the right time for someone to go and consider a cognitive assessment along with their regular body health checkups?
Right. So to be able to answer that question, there is no right time. Right? Every time is the right time. That's one bit. I am basically a community geriatrician. I work with elderly in the community and not in hospital settings. And in the community, when we actually interact with older people during our clinics, every one of these clinics, we adopt certain simple strategies. Right? So the simple strategies we use are looking at relating to medication.
Would you say that the issue is with accessibility with these screening tools, or is it an issue of awareness, or is it both?
I think it's both.
Okay.
So we have a large chunk of our population who lives in rural areas, right? So in rural areas, the challenge when we actually talk about online, screens, and when we talk about screens, which are easily available and accessible, it is more so for people who are able to use it rather than, for people in rural settings who possibly do not have access to that. That's one. The second is, even though there is a screen, the ability to understand that screen and apply is most important. Right? For example, there may be a screen that to be able to, use these screens, yes, but thereafter to be able to get a validation of that condition from, maybe your personal physician and ensure that, that is a condition that you're looking at, and it's not just something that has been diagnosed as a result of you not understanding, that particular screen.
Understood. Great. Ramani, I know Dementia India Alliance has got like a short cognitive screener test. And if you can talk a little bit about that, if it's available here, and also how is it helping people? What have we learned from being in the space for I think now about 8 to 10 months now, like delivering these at scale? I think they were one of the first ones to actually drive this at a national scale. So some insights there from your experiences.
I think when you were talking about Ivory, one of the questions you opened about was every year you all get your blood screen done. Do you do cognitive screening? I think it's a standard thing that any of us who are in this space, we try to say. And the idea here is that one of the thought that we want to bring in forward is that you treat your brain health or your mental health as same as you would treat your physical health. Many times when we speak to our elderly audience, we always understand that if they have say 1 or 2 dizzy episodes, they know that it's not normal. They want to go to the physician, they want to get checked. But say they've gone to the fridge and they've forgotten what they've come to take, in the fridge, or they've forgotten a couple of things in their daily routine. They're not that much concerned. So first of all, there is a need of lot of awareness that is required, and that's the reason why when Dementia India Alliance started, one of the things that we took it at the forefront was how do we do awareness and how do we make people aware that it's okay to get yourself screened, just like how you give your blood test. Usually we give a very simple example that for sugars you do your HbA1c, which tells you you're borderline diabetic, you could become diabetic, and you try to work on it so that you don't become diabetic. Just treat it something like that. And that's the reason we started with an online memory screening service. We called it Dem Clinic, and our idea was it's completely free. We make it free, and it's not that online they're taking automated app or anything. We have a trained psychologist or a social worker administering the test, and it takes good 25 to 40 minutes. In fact, we take those history, we find out what are the risk factors. It's not just about leaving a person with just a memory screening and saying you have a cognitive impairment or not. Here the idea is, when you're taking history, you're making the person aware, you're making them introspect what has happened in past 6 months. Have they been forgetting? Is there any lifestyle change? Have the family noticed it? So we are trying to sort of make it more comprehensive and not add the fear of cognitive assessment here. And the idea that we bring forward is, of course, what Dr. Thomas also highlighted, that 45% of risk factors, we can work on it. It's not something that you cannot manage. And I always try to say diabetes is also not treatable. You have to manage it lifelong. Let us try to look at dementia more in that lens. Let's look at the risk factors. Let's try at managing, not give it more a scary outcome. That's the whole idea.
Got it. I have heard now most of the panelists talk about awareness. So I want to ask you, how many of you are part of at least one WhatsApp group? So you know what you have to do, right? If we are in the part of this room, at least make people aware that, did you know that such a thing is even available, right? I think that's it. That's all you need. And if all of us can make that impact in our day-to-day lives. I want to turn a cynic for a moment, Jwala. So far I've been an advocate. Yes, please.
What was mentioned was very important, but it's very important also to ensure that you spread the right information.
Absolutely.
Right, so there's a lot of disinformation out there regarding some of these conditions. Every other day, we actually get forward saying, based on whatever reality, this is something that is very important for you to open and see. And when we open the message, we find that there's a lot of disinformation out there. So when you forward those messages, ensure that the right message is forwarded. When you forward a memory screen, right, ensure that the right memory screen is forwarded.
Yeah, absolutely. Great call out. I'll just wait. So far, we've all got the importance of cognitive screenings. We hear that it has impacted people in different stages. We've understood that things can be improved or maintained. So for 30 seconds, if I turn a cynic, and this question is for all of you, I don't want to do a cognitive assessment done. Even if I find something is wrong, you can't do anything about it. That's what I have read. Change my mind.
So I actually had someone like that recently. I think one of the things I would point them to is, one is a lot of cognitive issues in older age is not dementia, not necessarily dementia. So there are treatable conditions. Dementia is very multifactorial. We know enough from the Lancet Commission in terms of risk reduction. So those interventions can make a huge effect, whether it's sleep, diet. So it's really, really important that we push them to go ahead, do a cognitive screen if they feel there are changes, and try and intervene in the right place. So I think a lot of the times people don't want to do a screen because they want to know what next. And there is a lot that we can offer next. And I think that's what we need to focus on.
Got it. Yeah. One short,
Sure.
snappy.
I think that is something we hear like almost in every screening camp. This is something that we definitely hear. See, I think one of the right examples would be the topic that we have put today. We have said brain health in action. We wanted to call it a dementia workshop, but we were sure that we won't have this level of turnout, so we called it the brain health workshop. So it is important that you package it in a way that is digestible to somebody, you know. That is very, very important. So many times you may have to package it more like a healthy aging sort of a thing. You have to approach it more on a risk reduction sort of a thing. I think that's what Jwala is also saying. When people say that I've heard dementia is not treatable, or any cognitive condition for that matter is not treatable, I really don't want to look at it. I usually tell them what's good for your heart is good for your brain. So you are going to ensure that your heart is going to be okay, right? You do all the physical activities and stuff like that. Just with those 4 or 5 things, add 2 more to look after your brain as well. So I think that is one thing. And second thing is, I think it is important to not just have the conversation with the person who has the cognitive issue, but have the conversation with the family. It is very important because I think the younger people are more open to actually seeking help when it comes to mental health conditions or cognitive screening. So maybe having the family being part of the conversation really, really helps. And that's the reason awareness is never for one single audience. It is for the community and it is for the society. More aware we are, more easier it will become.
Yeah.
People, in case they develop display symptoms of cognitive impairment. So that brings down the fear and the stigma in terms of accepting that dementia is something that is realistic and it can happen. And if it does happen, I need to actually take it in the right stride.
Got it. Dr. Shrikala, do you meet cynics like me?
Yeah, I think, we need cynics because it clarifies the air. Because people should not think elderly like me, and also the relatives should not equate, because they all come under non-communicable diseases, so that there is no infection. So hypertension, diabetes, and many of the autoimmune disease, movement disorder, all the neurodegenerative diseases come under non-communicable disease. But what you need to understand is, if I have a cardiac condition, and Dr. Dominic talked about the advance directive. If I tell in my advance directive, that means the health will, that if I have a heart attack, do not revive me with the fibrillator. Then I die. All right? If I am a diabetic, high diabetic, and I refuse to take insulin, either I will go into very low hypoglycemia, and I may go into delirium and die. If I say do not take me to the hospital, okay? Each one of the conditions, if I have a stroke or a cerebral hemorrhage and I say no going to the hospital, I will die. So there are critical conditions which also they are the cousins of dementia who have an immediate mortality. And many of you will think about I should have a death which is in my sleep, so that I do not suffer. We are not worried about mortality. We are often worried about morbidity. And that's the reason why we should have cognitive screening. Because if I am diagnosed with dementia, I am not going to die tomorrow or the next year. I am going to some of the people who have lived with dementia 25 years. And during this period, I am going to be miserable, and the people who are going to be looking after me, whether it is my family member or a paid care person, they are going to be miserable, and there will be so son will go. I had a nurse who had 13 children. So they used to divide her because she had behavioral problems in her dementia. They used to keep her every month in one child's house because they couldn't tolerate her behavior. And you just imagine for her to know where the toilet is and why won't she have soiling and incontinence. So what we need to understand is dementia is different. People never talk about Parkinson's disease like that. Because you start having tremors, immediately you are willing to say, oh, something is wrong with me and I'm willing to go to the doctor. And then see the neurologist and then because it is affecting me. But many people, when it comes to dementia, it is the other person who's suffering unless I have a lot of depression and psychotic symptoms of somebody taking away my money. And all these things are going to happen if I do not prevent it or to certain extent delay it. We never talk about stopping it. I am talking about in cognitive screening and having other areas of healthy aging is towards delaying it and using up the bank credit of either education or social connectedness. So you are living on your savings in the brain and in social relatedness before we die. That's the idea of cognitive awareness, cognitive screening, having a healthy lifestyle, brain functioning. Because dementia is not a critical condition where we are going to die. I'm going to be a burden to me and to the person who's going to look after me. Towards that, I should screen myself. And I think I will add, people have been talking so much about awareness. I think you have talked about everybody else. I feel very, very sorry. We all go for, all of you are put the responsibility to them. And we are all doctors here sitting. And I'm sure there are enough number of doctors here. Which doctor, diabetologist, says, you're 70 years old, sir. You've been coming to me for 30 years. And you're on insulin now. I think you must be having some problems with your brain also, with your cognition also. I have two. Please get it done. I'm your doctor, cardiologist. I'm your family physician. I'm willing to do this test. How many doctors are aware? We are talking about the individual responsibility of the family responsibility. What about the responsibility of the medical community? They don't have any responsibility to become more aware, get trained. Tell that to their clients when they come to them. No doctor does it. I've seen that because I work in a endocrinology setup. They will say, oh, so 1 year over, get your cholesterol done, lipase done. But they never say it even to an 80-year-old person. Sir, can we do a memory assessment for you? So the responsibility, because when you say about awareness and somebody talked about accessibility, it is also about, accountability, affordability. We all belong to middle and upper middle class. What about the rural people where the PHCs doesn't have the doctor and the doctor is not trained, doesn't know about dementia. So a person who goes there, an 80-year-old person who's diabetic, so what happens to that person? So when we talk about a lot of these awareness and dementia promotion program, we need to have awareness, accessibility, affordability, accountability. Because that doctor should be accountable for that person to follow up. So there is a lot of responsibility in the medical community which we pass the buck on.
Yeah.
And there are very few geriatricians who will say, okay, this is, you have to get it done. It rests with the family physicians and the primary health physicians and the cardiologists and the diabetologists and everybody else.
No, this is a very, very important point that she raised. I just have one last comment from the panelists and then we'll close for questions. And this is really just to ask, and one of the... yeah, I want to leave you with suspense for 30 more seconds. But the one thing that we have learned at Ivory is that taking care of your brain health is not necessarily playing Sudokus and also doing cognitive study. And all these panelists and all the doctors you met previously will tell you, you take care of your physical health, you eat well, improve your quality of sleep, you will automatically be improving your brain health. Okay, so it is not that difficult. You just need to be aware of everything else that's going on. So my last comment for the question, very quick, 10 seconds from each. One thing that you would recommend your own loved one to do for better brain health?
I think, definitely communicate well.
Okay.
That is, important. Nowadays, we are in the age and time where the mobile, is what we are actually communicating with, most of the time. So I think speaking to each other, communicating, with friends, family, with, your circle of people around you, that is a very, very important component that needs to improve. And communication does not mean to say, waking up every day with a good morning, hello, that kind of a message, right? Trying to actually call up somebody or go out and meet maybe, your neighbor, right? That is, I think, the most important aspect, to keep the brain, active and stimulated.
Great. So, one. Ramani, in no order, yeah.
Yeah, I think I'm just going to follow up on what Dr. Pritesh said. I think Earth is the only planet which has got people. We are full of people. And in this world, loneliness is an epidemic. It's an irony. So I think it is important to understand that loneliness or depression is a huge risk to dementia. And if I had to give an advice to my loved one, it would be to go out, to socialize, to make friends, and also you should be able to see and hear better, to look after your vision and your hearing.
Okay, so that's +2 for social connections, by the way. The immediate thing is please go out and call up a friend.
I would
Joanna.
say +3 for social
+3, okay.
but also finding meaning and purpose is really important. So post-retirement, you need to be flexible, try different things, whether it's cooking breakfast for your wife now or doing the accounts for your husband, whatever it is, be open, flexible, and physical activity is really top priority. So be as physically active. If you can't get out of the house, just move around your own house. Don't have the same couch. Don't sit on the same bed. Keep moving.
Dr. Shrikla, you have the final word.
I always believe in volunteering.
Okay.
And you can volunteering without any expectations. When you say volunteer, you don't want the name, fame and everything. So you can volunteer over the net. You can volunteer. Some people, elderly, if they are very multilingual, they are willing to translate. I've known a lot of people who would do translation for others, for authors, if they are very good in writing pictures for a children's book. So volunteering and giving your time. I'm not saying that you should give all your time in a day, but if somebody could volunteer 1 or 2 hours for somebody else is good. and not expect anything out of it, because it will give what Jwala said about relevance to you, that you have some meaning, and it will bring you social connectedness. One follows the other. So I always believe, not only in elderly, but even from a very young age, I believe that volunteering is one among the things, but volunteering should never come with expectations that I did this and I'm doing this for you, and you are not even thankful for it. That is very, very important.
On that positive note, I'm happy to share that I'm a transformed man. I have completely, I'm no longer a cynic. And with that, we close the session. Roger, over to you. Thank you once again to all the panelists. I'm so glad we went in such depth on such a important topic. Really appreciate it.
Thank you so much, Isaac, for moderating this. Again, put your hands together for Dr. Srikala, Dr. Bhupesh, Ms. Ramani, and Ms. Jwala. So I think, should we request all the panelists to come back on stage so that we can take some time with the question and answers. So if you've noted down your questions, or even when we ask the question, they can stand up and answer, whatever works. So if you have questions, just put your hand up, I'll pass the mic to you, and then we can ask the question. If you have a particular question for a particular panelist, please specify who you want to ask this to as well.
Thank you so much.
There seems to be a break time.
Shall I ask?
Going on.
Yes. I enjoyed both the sessions very much. Dr. Srikala is here. So I'm a doctor. I'm also a psychiatrist, so I'm going to respond medically. I wish more non-medical people would do this. Yeah? Sir, you asked a question about cognitive assessment. Right. Yeah? Right. There is no need to be very formal about all these things. Right. The British in their wisdom have worked all this out. I arrived in UK in the 80s and found something very interesting on the chart. The average age of the patient was 65. Huh? The two things the doctor would write is with it and on the ball. Okay.
With it or on the ball?
With it or on the ball. This means, are they in full consciousness or are they mentally sharp? Yeah. I'm also a psychiatrist, so I have to ask about their interests. You get into their interests, you can informally answer all these questions. Talk about RCB, you get it. Pretty smiley, you know? Yeah. Unfortunately, nowadays people don't watch. Middle-aged Hindu lady, the one serial which I've never watched, but I know about it from my mother, Putta Gauri Madhve. You get all the details. Right. Politics. Yeah, you can assess these things informally through all these questions. You do not need a formal assessment. 1. 2. The human condition dictates that nobody wants to accept their illness. So if you say dementia, they don't like it. If you say schizophrenia, they don't like it. Whatever. You give it some other term. But the problem pertains and you have to assess. There is no other way. It is better to do it informally rather than formally. 1, if they can't answer the question, set up the question in their minds and then talk to the relations. You can do this quite easily. Thank you.
No, really appreciate that point.
I have a question to anyone. I mean, it doesn't have to be a particular panelist. What are the things? All these people said, how do you avoid dementia or make your brain exercise? I have some questions written. Keeping engaged in WhatsApp, does it help for your brain? I will complete all my questions. I'll read all my questions so that people can answer. Keeping engaged in WhatsApp, because you are not talking to each other, but you are really engaged in your brain. As if you are talking to somebody, you are writing messages, you are reading messages, interpreting messages. Does that actually help you to, does that help your brains to be exercised, or does it have a negative impact just like watching the TV? Then how much social life is good? Going to gym, does it help your brain? Making your, say for example, I'm an auditor. Does that mean that I'm always thinking, I'm finding out what tasks to be done? Does that mean that I will never get into dementia? I'm doing my own taxes. Making taxes is not an easy thing anymore. I mean, there's so many rules, so many things. So you're thinking constantly, you're doing something. So does that help to make sure that you don't get dementia? That's another question that I have. Then what about the lawyers, doctors, scientists, mathematicians? Do they ever get dementia because their brains are so engaged and they're always thinking and doing something? So that was my immediate question. And also, when I also sing. And when I sing, I have to look at the lyrics. I cannot sing, I cannot memorize my lyrics at all. Does that mean I have, memory issues? Because no matter how many times I sing the same song, I still have to look at the lyrics and then sing. Does that help? And hobbies, somebody said you should keep your hobbies. So singing is a hobby. Does that help improve your memory and also help you to avoid getting the dementia? The reason I came to this session today is my mother is 92 years old. She was very strong in memory. This is 80, 85, 86, 87, started getting into dementia. And her mother also had dementia. So 92 years now, I think her memory is about half an hour or maybe 45 minutes. She will still remember only 45 minutes before and not anymore. So I don't want to get into that kind of a situation. So I came here to see what can I do to get better.
So, give the panelists one.
I think there are many questions for each one.
I think I can summarize that the key thing that I always tell people is try to be out, mingling with people in person as much as possible, because I think that you have your physical exercise, you have more cognitive stimulation when you're out. If you don't have an option and you're just stuck at home, you have mobility issues, then if you're engaging with WhatsApp, that's great, as long as it's just not looking at very negative videos, because there's a lot of videos that get shared and people are just constantly using that as entertainment. So I would say that's not great, but if you're talking to people, engaging with people, planning a party, great. With regards to doctors, scientists, everyone can get dementia. I think the key here is how diverse you are and how you do different things with your brain. So if you're an auditor and you're singing, that's fantastic. And if you can do some art as well, that's great. So I think just engaging in different activities is really important. It's not so much about what qualification you have. Yeah.
And gymming is great.
And gymming is great.
I just want to say that, sir, the idea of dementia is to delay dementia and not to avoid it. The older we become, age is one big risk factor. The older I am, the chances of my having dementia are much higher. So your mother was well till 85. Great, that means she has done a lot of good. And her suffering with dementia and putting a burden on you is only a few years, because she's going towards, we already talked about death and dying, so I don't have any issues with that. So unlike a person who develops it at the age of 60, that person has a 20 years of living with that. Whereas your mother, she still has 45 minutes. And before she is declared as moderate or more dementia, she may be 90 and she might have gone. So the idea of all these diverse things is that it will not, because scientists, Nobel laureates can get dementia, sir. So naturally, but what is this? The reserve is more. So you are able to have a better life. But the idea is even the richest person can become poor, isn't it? But you have a longer duration to become poor rather than a shorter duration. I'm sure Mukesh Ambani, if he has to become poor, he will take at least 3 generations to become poor. Rather than me, I can become poor in no time. So that's the idea of the diverse, all the 14, things which we talk about. It is not about totally avoiding dementia. That I don't think anybody can do unless somebody comes up with something, and we'll get a Nobel Prize for that.
Sir, one second.
I would like to add, So the important thing here is, many people have a question, how can I avoid dementia? It's not about avoidance, it can come to anyone, right? But what is important is the aspect of what we call healthy and graceful aging, right? A person with dementia can also age healthily and gracefully. Yes, he or she has dementia, but the way in which, he or she, copes with that dementia, his or her family members, cope with that dementia is also important, right? So coming back to some of your points, sir, WhatsApp, I would certainly not say is something that will keep you active in terms of, mental health, right? In fact, there have been studies underway to be able to look at the negative impacts of social media, right? You have people all the time, addicted to, the screen. if you actually travel by a bus or by public transport, you will see people around you, going on clicking photographs, smiling like this, immediately, clicking a photograph, and within seconds it goes to 10,000 people. Those 10,000 people are interested to see how many other 10,000 people are posing in what way, right? The so-called what do you call that? The DP or your status, right? So you have people continuously going on changing their status, continuously searching, what somebody else's status is, right? So these kind of things can be very addictive. They can prevent physical activity, right? So I would rather say go out, walk around. The question of going to the gym, will it actually improve my mental health? You want to go to the gym, you want to actually take a walk in the park, you want to actually just climb a flight of stairs, 4 times, if you can actually do it. Any of these things actually will stimulate your brain, because physical activity is known to actually release certain substances in the brain which actually promote wellness of mental health, right? So physical activity is a very, very important component, and with physical activity you remain active, depression comes down, right? The moment you're actually just sitting in a place doing nothing, your mind is not doing much, right? So depression and mental health can be linked to lack of physical activity. So very important. Medical conditions, right? If a person has a brain tumor, that person may develop actually dementia, right? There may be memory loss. If that brain tumor is actually taken care of, maybe the dementia will be taken care of. Or if you have vitamin B12 deficiency, you may have some amount of memory lapses. You take care of that B12 deficiency, it can actually get sorted out. So it's important to be able to look at addressing what the challenge is and not just leaving it as it is.
I think before we go to the next question, Dr. Dominic wants to add a couple of things as well. We'll come back.
No, I don't want to add anything. I just want to give a bird's eye view about what it is. I think if you miss this, you miss the whole point. What we are talking from first session and second session is this. Over the life course, we accrue a lot of risk factors, which affects a physical reserve and a cognitive reserve. What we talked about is how some risk factors can make it worse. How, as Dr. Srikala put it, where you start manifesting problem of cognitive dysfunction much earlier. My first statement is that aging is intricately associated with cognitive decline. Whether you like it, you loathe it, or you love it, just gulp it. That's the way it is. We all are going to get it. The question is, are we going to tide over such a situation that in 80 I don't get it? And also one more thing is we are trying to compress the morbidity. That's what our endeavor is. So that you don't become immobile for 10 years, you are immobile for 6 months. That's the best that you can do as doctors. So I think that's what it is. So I think if you miss the whole point, we are not trying to say we are mitigating, assuaging the risk. We are not eliminating the risk. Okay? I think basically that's what I wanted to convey. Thank you.
I am a family physician and also a child and adolescent mental health specialist. Part of my question has already been answered. It's about the digital media usage. See, the children, we clearly tell the parents like screen time, how much it's going to affect the development of the child, and having an online community of friends is no substitute to having real friends in the real world outside. So what I want to know is these two aspects in the cognitive decline. Is excessive exposure to the digital media, be it social media or playing games or whatever, is it going to have a direct impact on the cognitive decline? And also, having a digital community and thinking that is enough for me to have social communication, is that same as having social communication outside? Why I want to know is many people are like, I'm immobile, I don't want to move out. So is both the same, and does it have a direct effect on the cognitive decline?
Thank you, ma'am. I'm going to ask Ms. Ramani to answer this. She has a 6-year-old at home, so she's probably in a good position to answer this.
Okay, thank you for asking that question. I think one of the things that Dr. Preetesh said, I think I would like to go back to that. That when you are actually using a lot of screen time, one of the things it does is, it is very addictive. So when it is very addictive, what happens is you don't pay attention to activities that are actually very important. You know, going out, getting your physical activity. Many times at home, nowadays if you look, again I'll take a social media example as well. When you go to Instagram page, they will actually, they'll say, don't come to social media in social media itself. You'll have a picture of family, everyone sitting with one phone rather than actually interacting with each other, right? So it is important that you really have interaction, the true interaction rather than the telephonic digital community. What happened is during COVID, we were not able to see each other. We were not able to talk to each other. And then what happened, the digital media just boomed, right? It became a way of communicating. It became a way of staying in touch. When you have nothing else going on, during COVID, when you were not able to get out, you were not able to physically see somebody, definitely digital media aided in socialization. That cannot be taken away. So when you don't really have an option, social media keeps you connected with your family, keeps you connected with your friends, it keeps you engaged. Sometimes it also helps you to relieve your boredom, it takes you out of your loneliness. Yes, when the situation is like COVID. When it is a normal situation, always physical interaction is much, much better. At any given time, telephonic or a digital media space cannot really, sort of replace what we are able to do in a physical environment. So that's very, very important. So technology is here to help us, not to make us dependent. I think that is what we need to understand.
No, sir, before you go there, I think Dr. Girish and Dr. Preetesh want to add to that. We'll finish that and then we'll go to the next question.
So ma'am, just to answer your question with regard to whether cognitive decline has a link, with screen time, it's too early to say, right? Because it would require a long-term study. Screen time is something that is very recent, right? It's boomed in the past, possibly 10 plus years, right? And to be able to see whether children or others who are excessively involved in screen time do develop cognitive decline much earlier as compared to somebody not using screens would require a long-term study. But having said that, there's a challenge here because nobody is devoid of screen time at the moment, right? It's possibly the gradation of screen time. So yes, long-term studies are required. It's too premature to be able to say, is there a link in terms of scientific evidence? But it would require a long-term cohort of people, right? People who are followed up over a long period of time to be able to see their patterns of screen time as well as developing cognitive decline, right? But apart from that, what you did mention in terms of excessive screen time can have negative impacts in terms of obesity, in terms of possibly increased risk factors for various non-communicable diseases, and as a result of which, yes, these diseases actually have a link with dementia. They may actually increase the risk for dementia, right? So that's possibly the linkage.
Children are experts and we learn from them. My question, I think I have already said what is the effect of sleep on dementia, and two more questions are there. In many cities in the upper localities, the people used to stay individualistic, need not want to know or interact with the neighbors. What is happening in neighboring locality or neighboring house, they generally they don't know who is going, generally it is happening. So what is the effect of this on the dementia? And one more question is, in the fortnight there was a session in Bangalore, one of the Supreme Court judges was telling more than the divorces, the separation in the families is increasing. Rather than the divorce, there is a separate living is increasing. There is an issue in the society. I don't know how this can be addressed.
3 points which you brought out. One is on sleep, whether sleep would affect and how does it affect dementia. Second one was people, I don't know people saying next door. I may not know my brother or sister or my 2 children will be in 2 separate rooms and they talk through WhatsApp. That's could be an issue. The third one is there more cases of divorce, or are people staying in the same house but living separately? Okay, I will just leave it to the other panels, but just the thought which our accountant, CA raised, and also link it up to this question. Definitely I don't want to be Shri Girish Ji sitting here giving gyan, sleep for 8 hours, perfect sleep is good. We all know those ideal situations, and we also know that there are several things which come up on a very practical issue. That is where Shrikala Bharat madam is there. The point what she mentioned as part of person is not able to do what they want to do every day. That's where it could be as simple as person wearing, she was mentioning the word
Sari
wearing a sari, or doing their regular activities. I think that's a thing which I would like you to focus on. That's where is my point. As a public health practitioner, I look at the counterfactuals. What else is there and which is what. Just to give an example, we've been talking about brain stimulation games. It's in this context that NIMHANS is collaborating with the government of Karnataka to start we've started the brain health clinics across all the 32 district hospitals. It's one of a very ambitious program. Much before globally they thought about it, this concept, government of Karnataka took it up, and then we are looking at 5 primary disorders: epilepsy, headache, stroke, dementia is one of them, and the other neurological conditions. So brain promoting activities. So go to Gulbarga and ask people, okay, will you play these board games? Every day they're sitting below a tree, or many a times they know how to play the Chowkabara. Now you go and tell them you play Chowkabara. After that we had not done, so one of my postgraduates, she did what are the leisure activities for the elderly persons who are visiting NIMHANS. Need not be just patients, but also who accompany the patients who come to NIMHANS. 75% is TV watching. What the hell have we created? What are the systems available? 5:30 onwards, do you think we have a system here as to what I should do? Now, which is where I'm sure Dementia India Alliance is addressing that. We want you to be our partners in this. We want you to look at this in a holistic manner. I know there are issues. For example, when I talked about the Walking Plus program, how much should I walk? Is 10,000 steps? Did someone come out with that magic number of 10,000? I'm sure all of us have got our mobiles and then we have counted, did I today or not? Now suddenly after 6,000 steps, doing it for 3 years, sometimes you lose in stocks possibly, and then say, did I get dementia? Of course, we can't answer that question. It's very difficult that is where I said I should not become Shri Girish Ji. We have all professionals who have got our experience by interacting with the patients. There is some evidence which has come in, which is what we would like to share that evidence. There is a long-term thing which we should be looking at. We should be looking at systems which is available. That is where I come back to the question in terms of screen time. Yes, I agree with Dr. Preetesh what he said. NIMHANS has opened a new service. It's been running for almost a decade now. Services for healthy use of technology. Technology addiction is one big issue. The National Mental Health Survey, which we are doing across all 36 states, has got a very specific section on technology addiction, that is behavioral addiction, in which technology is also one part of it. We will get some numbers, I'm sure, definitely. But how do we go about as a society to respond to that? There has to be several things which could come up. Now, and during COVID time, we didn't have an answer. This came out to be the answer. We need to see what works, how we can make it work. Now, let's engage in that. I don't want to sound demeaning or putting you down, but please also understand there are some things which we can confidently say, which is where when Sir said about the larger issues which we face. Sir, you said you were a psychiatrist and looking at it. In condition of schizophrenia, what we have now resolved or reconciled to is saying, okay, they may have a lot of symptoms, but as long as they're continuing to work, continuing to live a meaningful life within their circumstances, I think we should be happy with that. I think that's what Madam was mentioning. Madam, I just would like to borrow that phrase and then say, let's look at doing our things which we think we can do better. In case I'm not able to do better, let's find our confidants. Probably one of them is a family physician whom we should be able to share. Things don't happen just one day. Those are emergencies. But many of these lifestyles, many of these NCDs take a period of time, and you require someone else to tell you that possibly something is not going all right. Now that is where let's build that larger system in place. Thank you very much. Sorry if I have got out of the context of paper.
I just want to talk about
This is regarding adding dementia testing to my annual health checkup. I want to ask you, Dr. Thomas, are these tests that you have designed at Ivory entirely objective? What I mean is, please.
Yeah.
What I mean is, if you give me a cryptic puzzle and I am not able to solve that puzzle in the time that you have then given to me, does it mean that I am really demented? And if you come out positive, does your finding map to something in my MRI which shows that there is indeed an abnormality which is causing dementia? The whole idea is to build credibility, to show objectively that what you are doing indeed is objective and true.
Yeah.
Then only it makes sense to add your tests to my annual health report. Thank you.
I'll address that. So, there is no one test which is the right answer to any perfect cognitive screening. I think you gave a very interesting example of how you can actually measure, cognition through just conversation. Think about the problem that besets us, and I want to set some context to it. India has more than 150 million people above the age of 50. We probably have qualified physicians like the kinds that we have today to the number of 50,000. There are about 8,000 neurologists, 10,000, cardiologists. I think psychiatry and counseling, all counselors put together is less than, 7. Will not be able to suffice the burden that lies ahead of us. Our entire bit is that it's not that try Ivory testing. I think I did not even mention Ivory testing even once during the thing, right? I actually said that get yourself tested with your nearby physician, ask them if they have something. Coming specifically to Ivory, we have a 30 to 35 minute neuroscience based testing. It's an FDA registered test. It does not give a diagnosis of dementia. All the clinicians here will tell you a diagnosis of dementia cannot be given by just us writing a single paper after you've written a test. It requires a multifaceted, pronged approach on, maybe a couple of years, after which a clinician will definitively say that this is probably, something which is going in the direction of dementia. Our test is a screening tool, which is meant that it's meant to be a non-invasive, accessible, easy tool for you and your loved ones at your fingertips to see if you're at risk or not. Alongside it, this benchmarks you. Coming to that specific cryptic puzzle, sir, that you mentioned, there is no right or wrong answer. It measures things like reaction time, accuracy rate, response rate, frequency of right responses. 32 different variables go into it, and then we are able to draw out a cognitive profile. What we do is that we define people at different stages. We say you're either excellent, or well done, or needs attention. Those are the three categories. In needs attention category, we basically put you in touch with a clinician to investigate for it. That's how we do.
What is the cost of the assessment?
This question also probably you can answer along with this. See, in the first panel discussion, you are mentioning about Lancet Commission, the 12 factors, modifiable,
That
reducible.
is Dr. Thomas.
Yeah. Out of curiosity, I just asked the universal uncle Google, what are the Lancet Commission factors? And one of the factors was on air pollution. Now I have a question for doctors. When I was born in 60s, the air pollution, probably the quality of air in Bangalore was good. And now when I am in my 60s, air pollution has, the quality of air has deteriorated. In case a person takes, say, a couple of minutes oxygen-rich air in the morning and oxygen-rich air in the night, is it going to help in the quality of the brain?
Okay.
In case you have not done some, probably on patients with dementia, you can experiment and then throw the results for all of us.
Sir, I'm going to ask Dr. Thomas to take that question, but before that, Dr. Shrikala is waiting
I
to answer.
definitely want to come back because people have been talking about screen time, WhatsApp, TV and everything. I think the message is, we are not, when we are talking about all those things, that's a child and adolescent psychiatrist or a mental health professional. I think I want the audience to know that we are talking about not the elderly. See, when we say elderly, even 60 to 70 is not an elderly now. We are talking about above 75, 80. Those people, they have a lot of restrictive factors where they cannot go. So in fact, I think TV is good, WhatsApp is good, but for the rest of the family who come to the table with the cell phone and not talk with the grandmother or the grandfather, never spend any time with the grandmother or grandfather, or check with them about certain things, or watch the TV serial together with them, and then ask a few questions, so to understand whether the grandmother really understands. These are things which need to be awareness. I said about the doctors, awareness to the younger family members. Most of the family will say, Ajji ki usharilla, hogi matadbeda. That's not the way it is. Even a healthy grandmother would like somebody to, even if the child is in USA, you can call them and talk with them every day for 45 minutes. You can use the technology and you can, you can play games over the net. So all these things, net time, in a way, after 80 it is Corona time only. So you better use the technology and WhatsApp and TV. But TV can be a very good method of understanding whether somebody, because watching TV is different, understanding and processing TV is different. They are two different things. Please tell all your children to spend time with the grandparents, whether they stay in the same house or the next street or the next country, and not come to the table with cell phones.
Yes, so I fully concur with Madam was telling, if that is so, you have to look at strategies for social connectedness. So the late life risk factors, I told you that we are all middle-aged, 18 to 40, 65. But more than 65, Lancet would have told the three important risk factors. One of which is social connectedness, which is social isolation. So social isolation has to be mitigated. That can be mitigated, at least that definitely. So that you can have more connections and all. So if you actually see, there's a lot of interest in studying people who are actually called super agers. So super agers are people who have cognitive capacities of somebody who are 2 decades younger to them. These are people more than 80 years of age. So that's by definition, but this is not the Indian definition. But if you actually see, that's something which is quite interesting. Now I'm not digressing from my question. So the question is about air pollution. So the late life risk factors include social isolation, air pollution, life visual loss, which could be due to diabetes or some retinal degeneration and other pathologies. But air pollution constitutes about 3% of the kind of risk factors for contributing to the prevalence of dementia. Now, there are many doctors in this particular room. So, just want to tell you that Bangalore has significantly changed. You are all witness of that. Now, Bangalore is also the asthma capital of India. Okay, so we are capital of many things, but asthma is definitely one of the things. Now, you look at air pollution, why it is important for dementia. It is due to both direct causes and indirect causes. The indirect causes are due to the lung diseases that you can have. So water is good for the heart, is good for the brain, we heard. And water is good for the lungs, is also good for the brain. So that's something which we have to understand. So there can be indirect causes due to COPD or due to interstitial disorders or due to other factors. It can actually cause a kind of prelude due to development of cognitive impairment. But most important is the exhaust pollution or the automobile related exhaust inhalation. There is some factors known as very small particulate matters, PM 2.5, particulate matter which is less than 2.5 microns. What happens when you inhale is that it can actually, so there has been some work done in CBR also, and what happens is that when you actually inhale that, it can cross the blood-brain barrier, and it can result in lot of inflammatory processes inside the brain, and can further result in immunological and inflammatory dysfunction, which can result in dementia. So pollution is something which has to be kind of addressed. This is a situation where it has to be addressed, especially in a place like Bangalore, which was supposed to be one of the cleanest and greenest. So I think we have to do at our levels. During the COVID, there were a lot of studies. You would also be aware of many newspaper reports that when mask was used, there was lesser kind of incidence of asthma, viral infections of other nature apart from COVID. So air pollution definitely has a big role, and we should all attempt to mitigate. And taking oxygen-rich thing has been tried in China. There are oxygen parlors. People go there, take oxygen, come back. But too much oxygen is also bad for the brain. You have to remember that. So it is maintaining a clean concentration of air. It's not the air pollutants that is more important. In rural, in our Srinivaspura population, we also see lot of use of what is known as use of fuels, which is more like cow dung or kind of using firewood, which can also cause ambient air pollution. But that is not there in the urban. We all use LPG, but there's lot of risk factors with respect to air pollution.
Thank you, Dr. Thomas. We can take one more question.
Last one. One of the panelists mentioned about RWA, right? I think so. He got off, I think. And that was a good suggestion. Now Bangalore is divided into 5 countries now. The government has already passed it. So you can bring down all this down to the ward level, because this aspect I feel, because I've been into the ward meetings, and all of them might have attended ward community meetings. So if you can bring this knowledge to that level, maybe RWAs, because the person was mentioning about RWAs. Now I think the RWAs play a vital role in putting all this diagnosis, putting in place. So community where they meet at the ward level, they'll be knowing all this.
So we'll talk about that, sir, when we're talking about DIA's work. One last question, please, sir. Yes.
The present sequence, like majority of the people here are no 70 plus. I'm in my 50s. Okay. So the present sequence of how we are going to face issues are BP, diabetic, then comes diabetic related cataract and eye functioning, then hearing impairment. So the moment somebody becomes diabetic, he tends to become lazy. Interaction starts. Interaction reduces. Isolation is coming to the isolation. So after getting cataract or before getting cataract also, that isolation increases. With hearing, it increases much more. At that stage, if dementia hits, how do you save him?
How do you?
Save him. Because already he has gone through so much of isolation. Dementia is also going to make it much more isolated.
Okay, Dr. Girish will answer.
Okay, I'll ask you, what do you want me to do? What do you want me to say?
During the conversation, we said that dementia is likely to have effect on our senses, eyes and
yes, definitely,
but
it does
now
have.
we are going to have decreased capability of the senses even
Correct.
before dementia.
Correct.
So, will dementia further degrade them?
See, I think Dr. Benjamin mentioned it. This is a concept wherein risk accrues over a period of time. And there is an addition of each and every component which comes in. When we are talking about it, we dissect it out and then give, because there is a mathematical model which we have. So if you ask me very specifically to what extent this, yes, definitely there is a contribution. But finally, again I come back to what Mr. Mr. Shekhar Madam mentioned and also Dr. Benjamin mentioned, look at functionally how he can be made much better in the existing with cataract. Cataract now we have got surgery, intraocular lens is there, so at least that could be addressed as early as possible. Hearing aid, I know there are hundreds of problems. I came to know about it once I started using it. Plenty. I can also now empathize with people who are not able to use it, but why they reject it. Question is, all these challenges are there. Please don't expect a perfect solution. What we are saying is, yes, there are challenges. Let's try to see what is the best which can be made possible with all those limitations. That's just a request. And a quick information about air pollution. Air pollution is now very much in the news because there is a lot of research going on, because we've been able to get parameters which could be measured. Just for information, I think when we looked at our National Mental Health Survey data, the first survey was done in 2015-16. We tied up with IIT Delhi, who gave us, as a joint endeavor, we were able to look at the past decade, that is from 2005 till 2015-16, what has been the cumulative effect of air pollution, because we do have satellite data, which is publicly available and all that. Trying to bring a cause and effect relation is always difficult. There is always a pathology which we can give about it. PM 2.5, yes, it's got various components. We know that some of them are very poisonous. If one part of the poison goes to any organ in the body, it has got its impact. So there will definitely be a pathology which will be a resultant of it. So just finding a solution in the morning or in the evening would not help, because it is cumulative. It accrues over a period of time. In this particular study which will get published, we were looking at for every 25% change in air pollution. Now there is a 1 unit increase in terms of depression and anxiety. This is across the country, 12 states data. So now we are getting to know that this is the problem which is cropping up. Loneliness, I think Ramani was mentioning. 2011, as a PG, I found a paper by American Journal of Public Health. Loneliness is the new epidemic. That was in America. No one had studied that much. Now we have got more data about how loneliness can affect us. Now, can I say that every 1 hour you engage so that loneliness is reduced, so that dementia would get reduced? It doesn't happen in that one-to-one. I think we need to look at it in a slightly holistic manner, so that 1-to-1, 1 plus 1 is 2 definitely mathematically, but I'm sure all of us who are there know it tends towards 2 is a better way to answer, both mathematically, probabilistically, and also in terms of life and living.
Sir, so one question, brain health clinic, you're planning to do it in Bangalore also?
Brain health clinic, the first brain health clinic was inaugurated in Jayanagar General Hospital. It is there in Bangalore also. There is one functioning in KC General Hospital. Every district hospital it is there.
Namura clinics, what is there in all the wards, right? It is there, that's what I just wanted.
Namura clinics is a different one. That is a primary health center concept. This brain health clinics is part of the larger HCD clinics, wherein we look at focused neurological disorders. That's the point. Pardon?
Hello, can I ask a question?
Madam, we are out of time, but okay, we'll take this one last.
Yeah. See, my mother is 90.
Can she just finish this?
Yeah, sure.
First 2 questions.
Yeah, I think the question about including memory screening or cognitive screening as part of the annual health checkup, that is something that we're all advocating for, that because what happens, even Dr. Srikala spoke about that physicians including cognitive screening as part of it. I think now in every hospital there is geriatric screening where they try to check your ears, the teeth and the body and everything. We're definitely advocating. I think Dementia India Alliance, through a lot of advocacy effort, we were able to get the dementia friendly hospital checklist with the NABH, and now we are training all hospital, we are sensitizing all hospital about dementia and why cognitive screening is important. So we are hoping that in 2-3 years we'll be there somewhere. Yeah. Ma'am, we'll just take one last question.
Yeah. See, my mother is 90 and I'm a caregiver. Other than that, I'm also a psychiatric counselor. I work with Samadhana Counseling Center. So, what I want to know is, she's 90, now she's able to recognize everybody. Most of the people, her sisters and all that. But once in a way, we see little confusion for few seconds, which disappears. Maybe when I'm talking to her, it comes and again she comes back. Is it a stepping stone for dementia, whether
I think yeah, for a 90-year-old, if she's able to do
aging.
Yeah, and is she independent with her activities of daily living?
No, now her speech is coming down and she's not able to walk.
I would request you to sort of take it with us offline, because I think that will be better. Because when we talk about personal case history, there's a little more information that we would need. And given just the paucity of time, we would like to take it offline if it's better.
That's okay. I just wanted to talk for 1 more minute.
Yeah, sure.
All of us are asking questions to doctors. I want that all of us, whoever we are here, most of us maybe 70 or maybe a little bit more or less. What we can do for our environment, that I am doing. What I am doing is, we are RWA, you were telling, no? So we are drawing, we have a ladies wing, youth wing, and also family this thing. So we have during the ladies this thing all brain games, like these mudras and some games and memory this thing, all those things we do. We draw the people in the community to come. Other than that, lot of activities and these talks by doctors and somebody who is more knowledgeable, we arrange it once in a month. So people of the locality, they are arranged. And all the, I see in BTM layout, and we arrange lot of activities for all the people to come and participate in that, which is a very big success. So our RWAs can really make wonders in community relations.
Sure. Thank you, ma'am. That was a very, very good point. Thank you so much. I think as we come to the closure of this session, we would like to just say that so much conversation, and I'm sure that many of you have so many questions that we would have not answered. But the idea here is to keep the conversation going. So we want all of you to please send us your question. You have our helpline number. You can call the number. It's 8585-990-990. Please call us. Please keep the conversation going. That's one. I think few of you have asked for educational resources on dementia. Much of it is available with Dementia India Alliance, even in vernacular language. We'll be happy to give you all that. I think one of the persons spoke about the RWAs, the Resident Welfare Association. One of the things Dementia India Alliance has been trying to do for last 2-3 months is approach all these associations, conduct these kind of awareness program followed with community screening. Many of you might be staying in apartments. Please approach us, help us. This is something we are doing for the society. It is our collective responsibility, so please do that. And I think as we come to the closure of the session, I would also like to thank all our eminent panelists. I think it is very difficult to get such doctors to stay back for half an hour. They have sort of stayed back and answer all your questions very, very patiently. So I would like to thank each one of them, Dr. Shrikala Bharat, Dr. Dominic, Dr. Girish, Dr. Thomas, Dr. Jonas, Jwala, Isaac, everyone, all of them, our partners, Ivory, Nimhans, Nightingale's Medical Trust, Center for Brain Research, for giving us this lovely venue. I think whenever we want to do these awareness programs, Center for Brain Research is very, very kind to give us this venue. And we are very happy to say that though all of you were sitting in the hall, we had 60 more people sitting in the classroom down and watching this live. So I think it is fantastic. And as I said, today we have announced a workshop which says Brain Health in Practice, and 180 of you turned up. I'm looking forward that even if we say it's a dementia care workshop, the same number of people turn up. It is about mitigating that stigma. Each one of you can do something
for the cause. You can go out, talk about it, talk the right information about this. You know, you can help us conduct awareness program. We'll be very happy to take such educational workshops, have more conversation around health. We'll be very happy to do that. So please keep the conversation going. We are there, all of us are there to help. And though all of us in our own capacity are doing screening, we are doing awareness, we are doing education, whether it's Ivory, whether it's Dementia India Alliance, whether it is NIMHANS, whether it is Nightingale's Medical Trust. Today you saw that all of us have come together to have this one single dialogue on brain health. That shows all our commitment towards the cause to see a dementia-aware society, to see a healthy aging society, to see people who are taking charge of their health. So that's the message that we want to leave you with. We are going to have this workshop frequently, once in a quarter, and we want all of you to keep engaging in the conversation. Until then, please stay healthy, look after your brain health, look after your physical health, and lunch is served upstairs, so please enjoy it. Thank you very much for being such a lovely, lovely audience. Thank you. Thank you so much. Have a great, great weekend. Thank you, everyone.
And I just want
Just 1 second.
जल्दी करो ना.
Nice, huh? Hey developers, join us for the biggest AI